Very good morning, good afternoon, good evening to all the respected dignitaries and faculties of this program. This is MATC Connect, which is a Mumbai Advanced Trauma Course Connect meeting, which connects global leaders to orthopedic surgeons in the whole of India. I thank all of you all for taking this time out of your busy schedules and joining this meeting. Without any further ado, we will move to the cases so that we can utilize this time for our clinical discussions and learning. So my first presenter in this meeting is Dr. Matias, and may I request him to kindly present his case. Over to you, Dr. Matias.
Thanks. Well, thank you for the invitation to Dr. Swapnil. I'm very honored to be here today. So I will present a brief case about an infected pillar fracture that was usually treated but developed some complications. And we realized that there are some gaps there that we have to solve with new technology. So these are very important to make sure to show these problems that we currently have. So I have no conflicts to declare. So the patient is a 72-year-old boy. He is diabetic, has high blood pressure, and is highly smoker. He falls from 3 meters height and gets this right pillion open fracture. So this was a very high energy injury. He has a Gustilo 3B, so he has a lack of soft tissue cover over the area. And he was treated in a center with this emergency surgical debridement, and also he was applied an external fixator spanning the ankle. And 2 weeks after, all the tissues are in more well shaped in order to approach to the soft tissues coverage area. He was treated with internal fixation with those plates that you can see there. And also a gastrosoleus flap was performed to cover all this area. At that moment, he was in good conditions, nothing special. But after 3 months, no clinical signs of healing, no radiographical signs of healing also, but there were findings of infection. So he was with some pus over the area, with drainage from the incisions. So he was in a very bad situation already. So the surgeons decide to go for hardware removal. They apply some cement with antibiotics over the area. And again, he was put over a trauma X-fix. All the cultures were positive for Staphylococcus aureus, so we have confirmed infection over this big area. When this was a further study, the compromised area of bone was around 7 centimeters. So it was a huge area of infected bone. And at this moment, we always try to see what options do we have. In this case, we think about bone grafting the area of the bone defect that we are going to create. We can see using masquelette in these defects, but as we all know, masquelette doesn't really work for lower limbs very easily. You have to get a couple of surgeries to get all the bone filling to become new bone. So it's a good option, but some way limited. Then we have this new bioactive glass that we use, which are good, but they don't work in really big gaps because they need some compression to start forming bone that connect. We can always use bone transport, and of course, there is always option for amputation if this doesn't go well. So we don't really have like a perfect bone defect filler right now. I think the two best ones are these True Match cage that are CT made, so they are custom made for each patient. So they are very, very expensive. and these are like a cage that you can fill with this graft, but has like different layers, so the graft stays there where you want it to be. But this is a very expensive option, and of course it's not 100% proof. And of course, as we discussed, masquelette in these two steps, cement and then graft over the area, is an excellent option, but it has some issues about the bone contact in the streams and about the new bone formation, which can take a little while, and you have to protect it. And in a very infected area, it's a little difficult to keep on hardware and to keep this masquelette over there. So we go for this option. We did a bone resection, which was a final defect of 7 centimeters, and we applied an hexapod in a double level construct. So from one area we were making the destruction, and for the other area we were making compression. In this order, we did a bone transport with this hexapod. And the area was uh, clean at that moment, didn't seem to have any pus active, but the bone was very dead. And after 2 months, we already have a 6 centimeter bone elongation, which is the usual that we want to do. We try to go around 0.7 millimeters per day. We try to go a little more slow, especially in patients age over 70 or over 60, and also in smokers. We always try to go a little slower in those patients to have a good bone regenerate. At this moment, of course, no active infection. We seem to have removed all the dead bone, all the infected bone. So we already have this 6 centimeter elongation with no active infection, and we have to start thinking. We can't leave the patient too much time in the next fix, because we know there is always complications, and like infection, local infection in the pins, or sometimes we can have issues about wearing this big X fix over time. So we have to think with the patient, do you want to stay a little longer in the X-Fix? We know we have to be, if we don't want to use any hardware, we have to wait at least 1 month per centimeter that we have elongated. So it's a long time in this X-Fix. We can go for double plating. We can go for a plate and a nail to cover the whole segment, or just nailing, just a big nail, which is one other of the defect that we have because we don't have a big nail. Um, and then, as usually when we do this bone transport, we need to get a good connection. We need to have a good bone healing at the docking site. And we don't have a real perfect bones docking site in Hazer. So we have tried this Bone Alive or the Fibergraph, which are the bioactive glass, that are really nice to work with. They are very easy to manipulate. They promote new bone formation, and also they are some kind of saved in a previously infected area because they tend to be like they can control the bacteria to growth again. So they are a little too bactericide in the area. So that's like a big thing, and we are using it more and more and more on these docking sites. But of course, it's not perfect. It takes time and needs some compression. And on the other side, we have usually used the extra bone grafting technique that is RIA, which we use usually taking graft from both proximal femurs. So you get a big amount of new good quality bone that to use in that area. But there is nothing that is still perfect, and maybe that's another part that we will see some new developments in the future. So with this, we decide to go for an early conversion to a proximal lateral plate in a MIPO technique, with the X-Fix still on, so we don't lose any of the length that we have get with the X-Fix. And then in the distal area, we did an ankle arthrodesis with some bone graft with a RIA. and an arthrodesis nail in order to get that this small distal fragment stay connected to the rest. And in these cases, always we have the the mean to considering the overlap of both hardware. So we have to overlap the plate over the nail so we don't have a stress area that can create a new fracture. So this was after the surgery. And here is another gap that we are seeing, and it's very, very hard to get that somebody can create a hardware that works with this. So we have to we need a nail that can protect the transport, and there is nothing that can have like a intermediate screw that can hold the intermediate fragment. So we usually what we do if we use a long nail, we customize the nail ourselves. And these are only off-label use of some nails. Now we have access to this new feed bone transport nail, which is very nice, but still it doesn't hold weight. And of course, you have to remove this nail after and maybe even exchanging to a different nail. So it's not a perfect solution yet. And this is the patient 3 months post-operative. We allow him at this moment to do full weight bearing. He was very happy. You can see how at 8 months that he has complete function of the extremity with no new sign of infection. So we were very happy with his result. You can see the flap over there that was very well integrated, no issues with the skin, with incisions, no more fluid coming over. And also we can see with the x-ray that we didn't have any important limb length discrepancy. So this was a good result after having a very, very, very complex situation. And for us, this was very gratifying, especially being in a barbecue time with this patient after 5 years when he's doing his life very well. So those were the gaps that I want to show you, and I think we have to start thinking how to improve and get a better solutions for those patients, because we have to do all these very tricky things with technology that is already like 20 or more years. Okay, so this was what I wanted to present you. Thank you. You're mute, Kenny.
Yeah, it's a wonderful case. And now let me just open the floor for a few comments from our respected faculty as to what they feel and what could they have done differently, or whether this is what everybody would have chosen to do. So anybody would like to make any comments? I would like to say that this is an excellent case, and for me, it's a eye opener. It is wonderfully managed and very well taken care of. I think it's a combination of a lot of skill, uh, a lot of hard work, and also some blessings from the Almighty, because so many surgeries, plates, nails, and everything going well without any further infections. I think it's wonderful. Yeah, please go ahead. And we'll take a couple of comments before we go on to the next case.
I think we have got a question, Matthias, that why did you use a plate and nail instead of long retrograde nail from calcaneum to proximal tibia? This question is posted by Harun.
Yes, thanks to Harim for the question. So the straight nails that goes from distal to proximal tend to be too into the anterior part of the calcaneus. So it's an option, but I always prefer to have more grip with a arthrodesis nail in the distal part of the foot. So right now, what I'm seeing some of these cases that some people is doing is going with a nail from anterograde, so from the knee distally, with these new nails that have this plastic inside, and you can put more screws to connect distally. You can have like 4 screws in the calcaneus. But right now I don't have those kind of nails available, so I have to work with a normal nail, which are not that long. And for me, other thing is that when I try to go as soon as possible to the conversion, because and in that moment you have an issue. If you want to put a nail, you have to be very, very careful with the ribbon and with the nail over the distraction bone, because it's a very, very soft bone. I don't know if this answers your question, Harry.
All right. One more question or comment before we move on to the next presenter. Uh, Anybody? Any any questions, comments, any other ways of doing this? Very, very challenging and wonderfully executed case. So
I think
I think
these are definitely challenging case, and the way it was handled was brilliant, and certainly highlighted the gaps that are still there, and science needs to fill those up. And our job is just to keep pointing at those gaps and keep asking questions. Very well done.
excellent,
Thank
excellent
you.
presentation, Dr. Matthias. Thank you so much. Wonderful presentation and wonderfully done case. We move on to the next presenter. That is going to be Dr. Yasir Khan from Pakistan. And Dr. Yasir Khan is going to be presenting proximal humerus fractures, failed ORIF, disaster at 32. A very interesting title, and I'm equally keen to see what the case is. Dr. Yasir, you're mute. Yeah, you're muted, Dr. Yasir. Dr. Yasir, you're muted. Can you unmute yourself?
Unmute. Is that okay now?
Perfect, perfect. Thank you.
Right. Okay. So yes, thank you, Prof. Kenny, for the invitation. Assalamu alaikum, everyone. It's truly an honor to represent Pakistan at this prestigious international trauma course. And today, as Dr. Prof. Kenny rightly pointed out, I don't want to simply present another case of failed proximal humerus fracture fixation. I want to tell you a story, because every difficult case has two sides. And the radiograph we analyze and the life behind those radiographs. My name is Dr. Yasir Khan. I'm a knee and shoulder surgeon, and these are my disclosures. I'm sure when everyone read the title, Failed ORIF Disaster at 32, most of you would immediately think that there may be a problem with the implant, that maybe the screws are broken, or the plate, or there's a problem with the biology. I would like everyone to pause for a moment, because this is not a disaster because a plate failed. It is a disaster because a 32-year-old young man has suddenly lost the function of his dominant shoulder at the prime of his working life. At 32, like anyone, he should be building his career, raising his family, playing with his kids, playing sports, and planning his future, and not wondering whether he will ever be able to lift his child again. And that changes the conversation completely. Approximately 18 months ago, everything seems like a routine. A patient presented in the emergency after an accident, had a proximal humerus fracture. He underwent an open reduction and internal fixation that was performed, and all of us perform this surgery regularly. The reduction looks acceptable, the fixation looks stable, and everyone walked away optimistic. But biology has a different plan. Despite satisfactory initial reduction and fixation, the patient developed progressive structural failure with humeral head AVM and resorption. And when he first came to me, he was not a happy patient because he could no longer use his arm. Every simple task has become a challenge for him. Reaching a shelf, putting on a shirt, his shoulder had become painful, unstable, and almost useless. And this brings me to the philosophy that guides our decision. Yeah. When anatomy is destroyed, the objective shifted from anatomical reduction to restoration of a stable, functional shoulder because the native anatomy was no longer reconstructible. And believe me, as we all are orthopedic surgeons, and we know this, that orthopedic is not about how beautiful the X-ray looks. It is about restoring function and improving quality of life. And sometimes those two are very different things. So when I reviewed his imaging, it wasn't one problem, as you can all see. There are multitudes of problems. The humeral head is not there. The tuberosities have been resolved. The cuff has lost its place of attachment. And there may be a possible pseudoarthrosis. That means that there's no stable fulcrum for movement. Ironically, though, the glenoid looks pristine and beautiful, but completely useless because without a functioning cuff, the shoulder simply cannot work. And we all know that. So for me, this wasn't a reconstruction anymore. It's like a perfect storm that just walked into my office. This was a salvage surgery. And then came the question every shoulder surgeon fears. What can I honestly offer a 32-year-old young man at the prime of his life? So I started thinking and I started making calls. The best option I got was to do an arthrodesis. Now, we all know that it might manage the pain, but functional wise, it's a disaster at its best. If we look at the arthroplasty option, we know the anatomy will not work because there is no cuff to stabilize it. If we talk about trauma implant like a HAMI, it is a guaranteed failure because it's doomed again. There are no tuberosities. So the decision for me suddenly becomes simple because every alternative dependent upon anatomy was no longer present. And only one operation depends on biomechanics instead. It's a reverse shoulder arthroplasty. Not because he is old, but because his shoulder had become old overnight. Sometimes for me, age is chronological, and sometimes age is anatomical. The patient had an anatomical shoulder far older than his birth certificate suggested. And the question is, and the question isn't, can we do a reverse? The question is, can we afford not to give a stable shoulder joint? And why I believe reverse work in these cases, because it changes the rule. And we all know that instead of asking the damaged cuff to lift the arm, we recruit the most strongest remaining muscle, which is the deltoid. And by medializing the center of rotation, we transform the deltoid into the primary elevator. Yeah, so think about our patient. He's 32, he doesn't have a weak deltoid. Actually, he has one of the strongest deltoids imaginable at this young age. So why not use that advantage? And for perhaps the first time, his youth become an asset rather than a contraindication. And this is exactly what I did for him. I did a reverse shoulder arthroplasty. It was a technically challenging procedure. As you can see, and those of you have experienced, removing those Philos plates is a nightmare. During the surgery, my assistant twisted the arm, resulted in a proximal fracture as well, which I had to hold with a couple of wires. But I was hoping and still hoping that it will become a rewarding procedure. And this is how he is 2 months later. He is improving. His function is improving. His pain is completely gone. His motion I have started to return. And not just motion, he's also smiling. and perhaps most importantly, his hope returned. And that is why we are here to help as an orthopedic surgeon for any patient that walks into our clinic. Now, naturally, I know what you are all thinking, that he's only 32. So let's look beyond opinion. The literature has evolved dramatically over the past decade. The long-term work that's been published and work from people like Christian and Lucas and Pascal have demonstrated durable functional outcome in younger patients. Yes, I agree, and it's been reported as well that the revision rates are higher in younger patients. But compared with the painful, unstable, non-functional shoulder, the evidence increasingly supports arthroplasty as the better solution. So, in my opinion, we are no longer asking, does reverse work? We are asking, when is reverse the correct answer? And of course, we cannot ignore the question of longevity. Will the implant last forever? Probably not. But modern implants are performing way better, as suggested by this article. It's a systemic review. So if we can reliably provide this young man with 10 years or more of meaningful pain-free function, then future revision surgery becomes a problem worth having, isn't it? So because the alternative, what we have is asking him to live the rest of his life with a useless arm, that to me is unacceptable. So bottom line, I would like to finish with one thought. As an orthopedic surgeon, we are trained to respect anatomy, but sometimes anatomy loses and biomechanics wins. This case challenges many traditional dogmas. It reminded us that chronological age should never be the only indication or, in fact, a contraindication for reverse shoulder arthroplasty. Instead, we should ask one simple question: what operation gives this patient the greatest chance of living the life he deserves? And for me, this 32-year-old, the answer was clear. Not because reverse shoulder is fashionable, not because it's technically challenging, but it is because the operation can help him restore his function and his future. Thank you very much for listening. Before I go away, I would like to invite everyone around the region. We run a knee meeting in Pakistan, which is accredited by the Royal College of Surgeons. It is happening this year in September. It is also approved by Matc Europe, and most importantly, to the Kyoto conference by CCOT, end of September. I know you guys have a lot of burning questions for me, a lot of criticism. I'm more than happy to take your questions. Thank you very much.
A wonderful presentation, and you've given one more perspective to a difficult problem. And if you can stop sharing now, I will open the house. I per se, I do not disagree with this particular solution, because I know how difficult it is to take decisions in one practical life vis-a-vis the ones which are recommended by textbooks and journals. So let me open up this discussion to all, and Dr. Sufyan is here. We would like to make a comment. Yeah, you are muted, Dr. Sufyan.
Okay. Hi, everybody. Hi, Yasir. Congratulations for this wonderful presentation. And I'm very happy to see such a controversial item, because definitely in short term, I said, because he's only 32 and only the debate is what will we do after 2025, because at 60, I think you remain young for work. And if once you have a large lysis of the humerus, the reconstruction became very, very, very difficult at 60, because you cannot do any more an arthrodesis of the shoulder. But what type of prosthesis can support the charge of the upper limb and give a good function for the patient at 60? Maybe for this solution that you gave him, he will have a good result to be an active person and to serve his family and so on. But I am afraid after 25 or 60, the solution will be very, very challenging. Unless I had some experience in shoulder arthrodesis for young workers who had gunshot, for example, of the shoulder, or some complex trauma of the shoulder. I think the result is not too bad at midterm and long term, because they get accustomed with these arthrodesis, and mainly with patients which are hard worker, hand workers, and who had to lift some weight and so on. And it's definitive solution, and the debates remain always controversial about this issue. Definitely the prosthesis, shoulder prosthesis, reverse prosthesis are giving good results. But if these patients unfortunately have an accident or community fracture of the humerus on the prosthesis, I think it will be much more challenging, and the situation is much more challenging at 60 when we have osteolysis or around the prosthesis and how to revise it. Thank you very much.
Thank you. Any other comment? We can take one more comment before we go on to the next presenter. So any opinions from anybody else who are joint replacement surgeons and trauma surgeons?
Matthias has something to say. Matthias, unmute yourself, please. And then
Yes.
I'll quickly answer.
Thank you, Yasir, for the case. In your opinion, since this is a problem when you have these very proximal fractures, what would you have done different in order to avoid this big problem on the long term?
Right. Okay. So there were a couple of issues with this patient. He had surgery almost a week after the initial accident. Okay, so the head was being dislocated for a long time. Having said that, we always try and preserve the head at the first go. So anatomically, the surgery was done in another center, and I think when you're doing an approach, you need to be a little bit careful and respect the blood supply and try not to cause damage to the blood supply. But this can always happen. We all know that. No matter how careful we are, there are so many factors that can cause this. So the initial surgery, I have absolutely no reservations. Whatever they did, they tried to fix it, and it just didn't work. It just didn't work. And he ended up having a painful shoulder. And what Dr. Sofyan said, and I totally agree, I'm relying heavily on technology, the way we are progressing in terms of technology, improvement in the implant designs, and the more and more reverse being done nowadays around the world, I'm sure there will be implants coming down the line. So hopefully in 10 to 5 years, I may not be practicing and someone else be dealing with this one. And we'll have better implants to counter the revision. At least if you could have a working life rather than begging on the streets, and worrying about how to make a living for himself or for his family. He's married with 3 kids. He's been out of job for the last 18 months now, or maybe more now, and with no source of income, relying on the family to support him. He needs to start earning. And if I could give him even 10 years, I think it's worth the problem having a revision later if it needs to be.
Great. I think that is a very optimistic way of looking at things. Wonderful. Thank you so much, Dr. Yasir. We move on to the next case. That is Dr. Toulouse, if you have joined. If he has not joined and is joining us in some time, then I will request the next speaker, that is Dr. Eric from Panama, to present his case on failed masculine technique for reconstruction of tibial diaphyseal bone defect in open tibia fractures, case analysis and lesson learned. Over to you, Dr. Eric.
you go. Sorry. Can you hear me now?
Yes, we can hear you.
Okay, sorry. Hello, everyone. I'm Eric Tortosa from Panama, acting CCOD national delegate for my country and also acting as Vice President for Latin America. I am really grateful to be here with you all today. This is my home country in Central America, squeezed between Costa Rica and Colombia, and that's our hospital, the second largest of the Panamanian Social Security Service, but located close to the border with Costa Rica, not in the main city. I have no conflicts of interest to declare. The images presented in this case were obtained and used with permission of the patient and his family, and we did use Chat GPT 5.5 for the graphics. The objectives of this presentation will be to discuss the frequent causes of failure using the Mascalet technique, present an illustrative cases, and do a short analysis and comments regarding the lessons learned so that we would not repeat this mistake again. We start by saying that in order to deal with this type of issues, we need to have a working knowledge of how to deal with bone loss, as Matthias has already presented, and also how to manage the soft tissue reconstruction. So we've come to rely on the use of the Mascalet for more than, or it's been described for more than 20 years, and it basically involves using a foreign body to induce an inflammatory response that will eventually generate a vascular membrane that will be able to support the grafting and application of bone to produce new bone. But it is not foolproof. There are reasons for it to fail, and we can basically describe them in 5 main groups. 1 being infection related, 2 biological factors, 3 graft related factors, 4 mechanical factors, and 5 patient related factors. The most common being, again, infection related, biological factors, and graft related. So the 3 most common, as I already said, again, persistent infection, inadequate bone graft, and mechanical instability at the fracture site. Now we move on to our case. It is a 17-year-old male high school student, son of a police captain in a rural city in Panama, who was run over crossing the street along with his mother and sister. So there were several injuries. His mother was critically injured, and she was treated at a local hospital, but he suffered a severe open tibial fracture, a grade 3C, with bone loss of about 6 centimeters, loss of coverage of the lateral, middle, and distal tibia. We presented an injury of the peroneal common nerve, so with a foot drop, and very, very contaminated. Naturally, the family refused amputation at this early stage. This is his initial x-ray. He was run over under a bridge on a very rainy Panamanian day and dragged under the wheels. So he presented again with a very comminuted and contaminated injury. This is the initial picture taken at this first treating center. He was treated with lavage, debridement, an application of an external fixator, and a negative pressure therapy unit. Very standard. As you can see, there is some loss of bone, but it still requires further debridement. So he was transferred to a hospital in Panama City, in the capital city, for treatment, but for reasons of economy, the treatment could not be completed, and he was transferred now again to another 3rd hospital during, and by the way, this is November of 2018. So about a month into his evolution, you can see how it is. There is loss of bone. We had talked of shortening the extremity, but the family refused the extremity or the use of a bone transport for reasons unknown. And the colleagues who were treating it at the time started applying cement spacers, medicated, and also antibiotic beads, homemade. This is December. Upon removal of the beads, now you can see more or less how the soft tissues are evolving. And we come now to the limitations of life in the third world. We don't have everything that you sometimes wish we had. Lucky Matias, who is in Chile with very, very good resources, but we have to work with one hand tied behind our backs most of the time. So as you can see, the red crosses indicate the things that we do not have. We have the negative therapy units, we have the external fixators, we can do the skin graft, we can do the flaps, we can do the rotation muscle flaps, some pedicle flaps, but we have no skill or locally available trained surgeons at the time for vascularized free flaps. So that was a very, very problematic injury. And we were dealing with a loss of bone of about 6 centimeters, as I had said. We go forward, and now we move on to January of 2019. We start doing a formal debridement and a formal resection of about 6 centimeters. We nailed the tibia in order to promote stability of the fracture site and apply a cement spacer medicated to the tibia and the fibula, as you can see in the pictures. And you have a closer view of how things stand in 2019, but there is a problem. As you can see, we have no soft tissue coverage yet. So we consult with colleagues, with hand surgeons from another unit who offered to assist us. This is, again, after repeated L&Ds and continued application of negative pressure therapy units. This is a short video. Let me just silence it. Again, you can see the surface. Let's move it along a little bit more, and you can see the medial side and the posterior side as well. There are some injuries to the posterior aspect of the legs, so that was also a cause for concern, which had been draining for quite some time again. And as I said, this is February. In late February, he's taken for spacer removal, application of bone allograft with chips. We used about between 5 to 10 cc's of bone chips. And again, even though we had an assistant surgeon who was more capacitated than us, in the end, he decided to do a local advancement flap, not a free flap, and also skin graft. And we also applied again a vacuum-assisted therapy, not negative pressure therapy unit with the result that you see here. You can see the graft placed there in both the lateral and AP views. And again, this is at the time of application of the graft, but there is a problem. There is no soft tissue coverage, and I don't have a mature membrane for this case for the graft to mature. The surgical site was covered again with flaps and graft, and a negative pressure therapy unit was placed in the donor site and in the graft site in the proximal tibia, and removed after 4 days. And to our great disappointment and shock, this is what we saw. There was already suffering of the graft in the middle tibia and also in the posterior aspect. At about 2 weeks, the wound started to come apart and started to seep bone, but we tried to keep it dry or to make it dry with, among other things, tincture of mercury and chrome. Again, this is the limitations of working in the third world. At about 8 months, the skin has healed considerably, but still there is an open wound in the front union of the middle and distal, through which there is still drainage of pieces of bone. So now we are fully at 1 year after the accident and 8 months after the application of the graft. And at this point, we lost track of this patient. He's moved on to another hospital where now he had 6 months, 16 months post-injury, was still draining chips. They tried again to do a new masculine, but it didn't work. And after several repeated procedures, multiple interventions, the family opted to have the leg amputated. Again, this is a 17-year-old high school student. This is 22 months after the initial injury. Going back to, again, the three most frequent causes of failure in masculine cases, we have persistent infection, which given the degree of contamination and the multiplicity of procedures and medical centers through which this patient had been through was common, although sadly, we never managed to isolate any organism while he was, again, under our care, especially in the early part of the treatment. Inadequate bone graft. It is said that there should be a ratio of about 1/3 autograft to 2/3 allograft. In these cases, we use mostly allograft, but again, we think we achieved a reasonable mixture. We still retain some mechanical instability, but as I said, our problem was that we did not achieve a working membrane because we had no soft tissue stable. So we skipped stage, the point to skip to stage 2 to apply the graft and have it mature. So again, our membrane is basically not functioning at this stage. And here are my mistakes, which is something that a surgeon rarely likes to admit. Well, infection control, again, as I said, we never managed to isolate anything, but given the evolution with the wound descents and everything that happened afterwards, we guess we did have some contamination with a low virulence agent. Mechanical stability, yeah, that's okay. Proper soft tissue coverage, no. Again, we did not have the ability to perform flip flaps. We did not have a mature membrane. We tried to mix the bone graft as good as possible. And again, we were not ready to do the second stage because somehow the other colleague persuaded me to do the grafting at the time of the flaps and not wait for the membrane to mature. As Matias said, well, what could I have done differently? Strict vigilance for infection, high risk of infection to consider, again, another alternative such as a bones transport. In all cases, to procure a better soft tissue coverage, seek vascular collaboration for a free flap or an anterolateral thigh flap or latissimus dorsi. And we've had very good experiences with the use of dermal regeneration matrices, which again, given how the soft tissue around the bone was, the muscle bellies had already grown a significant amount of tissue over them. We think that we could have gotten a little bit more had we had this regenerative dermal matrices available at the time. So my take-home message and conclusion is that in order to have a successful masculate, you must be aware of the most commonly made mistakes, but also make sure that you have a good and healthy soft tissue cover, because it will lead to an inadequate flap coverage, scarred and soft tissue envelope, vascular injury, chronic edema, and of course, recurrence of infection, a poor membrane vascularity, and we will have, sadly, a delayed bone graft incorporation with a high risk of delayed union and non-union. I have some selected references, not all that were used, but some of the most relevant, including the use of a masculate over a nail. And so we come to the conclusion. This is the end of my presentation. This is a view of Panama City. You're all welcome to visit for CICOT in 2028. And again, I am very grateful to Professor Swabnin for the invitation, and I'm ready to take any comments or questions that you might want to add.
Thank you, Dr. Eric. At the outset, let me tell you that it is a very brave decision of yours to present your own failure. We do see so many patients who do not have optimal outcomes, but we never ever end up presenting them. So So I don't have any comments, but I should say that you are a very brave man, that you presented something which is common, but somehow never presented in any of the meetings. Right.
Yeah.
I'll open the forum for discussion. Professor J.S. Kulkarni, sir,
Yeah.
you have your comments.
Yeah. Eric, you have not made any mistakes. It is the mistake of the infection. The main cause of muscular failure is infection. We have large experience with bone transport and muscular technique and tibia and femur. Our experience shows that tibia muscular techniques usual failure is very common, and bone transport is much better in tibia than in femur. Femur is better to do muscular technique rather than bone transport, because bone transport may cause stiffness of the knee and other things. So we should restrict ourselves not to do any muscular technique in tibia, and we can try in femur and not in tibia. That's my comment. And Eric, it is not your mistake. It's the infection that is the cause of failure of muscular technique. Thank you.
Thank you, Professor Kulkarni.
Yeah.
Sofian?
Thanks, Eric, for this very interesting case. I think, as it was told, it is not really a mistake. But the problem, the challenge for you was to find the good solution how to cover the distal tibia where it is
Yes.
very difficult. Okay, but I think I don't have any idea about how this soleus was. Because there was an option for reverse distal soleus fascicutaneous flap. But at the moment, I think it's not reasonable to go for an amputation, because you can manage it more with this small drainage, and because he is almost healed, there is as a regular reunion of a tibia. I will remove the nail, put an external fixator, compress the site, and try to find a small muscle, local muscle, or you still have the cuff, which is intact. The cuff is intact. I think you can have a reverse soleus fascicutaneous flap to return it back, and you will cover the distal tibia. That is among the best flaps for the distal tibia. And since you already have the muscle over there, that fascicutaneous will be enough to cover it. And I will not go for amputation, because we can solve it. We can remain and solve this patient, maybe even just with an Elizarov. If you go for an Elizarov, you compress it, and you have a lot of chances to have a healing of the tibia.
Thank you.
Thank you
Our
very much.
department had at the time more than 20 years of experience with the use of bone transfer shortening and lengthening with monolateral systems, mostly through the Orthofix brand. We had no experience in Panama with circular rings or the Elizarov systems. Recently, we started to have, about 3 years ago during the pandemic, they started bringing in hybrid systems for mainly tibia and ankle fractures. But at the time, we had one hand tied behind our backs because the family refused to let us shorten or do the transport. So that was one. At the time, we didn't have the experience that we had, or the staff experience with some of the flaps that we require for orthoplastic work. And we had very poor collaboration with the vascular surgeons at the time in order for them to assist us with free flaps, which was another very, very limiting problem in this case. I agree that we could have tried some type of local flap, but we were not convinced yet. And again, when I asked another colleague to assist with the flaps, we changed the plan at the last minute and ended up doing just the advancement flap, which proved to be insufficient in this case. On top of that, yes, we did end up with an infection at some point, but sadly, we could never isolate anything. Thank you
can
all
stay
for
with
your comments.
monolateral. You can stay with monolateral, no need for Elizarov. Elizarov is it's much more easier for them to walk, but you can stay with monolateral or posterolateral flaps.
Right. Wonderful. Thank you, Dr. Eric. We move on to the next presenter, uh, Dr. Toulouse, if you're here, and he has a very interesting case. Uh, Dr. Toulouse, Dr. Toulouse, can you hear me?
Oh, yes, I can hear you.
Yes.
Good afternoon or good day. I'm not sure whether it's evening in India or not at this time.
Yes, it is. Please go ahead, Dr. Toulouse.
Okay. All right.
You can share your screen now.
Yes, I'm getting to it. Just give me a few minutes. Okay. I suppose you can see my screen now.
Yes, we can. Thank you.
All right. So I'll be discussing a case briefly of neglected cervical spine dislocation with intact neurology. Okay, so I have no relevant disclosures. I practice at the National Orthopaedic Hospital in Lagos, Nigeria, which is also an AO Spine and CCOTS Fellowship Training Center. So the case I'm presenting is a case of spondyloptosis, and just a brief introduction to it. Spondyloptosis, usually following trauma, signifies disruption of all the three columns of the spine with high-grade instability. The non-traumatic causes of spondyloptosis would include aneurysmal bone cysts, Klippel-Feil syndrome, neurofibromatosis, absent posterior elements. Usually, it's commoner in the lumbosacral spine as a developmental disorder. Only a few cases of traumatic spondyloptosis in the cervical spine have been reported in the literature. The case I'm presenting is that of a 38-year-old female who walked into the spine outpatient clinic on account of 2 months of unrelenting neck pain following road traffic accidents. She had no neurologic symptoms or comorbid illness. She was ambulant. She walked into the consulting room with and the singular complaint she had was the unrelenting neck pain. Radiograph that she presented with that was ordered for CT scan, which was ordered for, showed angular kyphotic deformity of the cervical spine with spondyloptosis of C4 over C5 vertebra with bilateral C4-5 facet dislocation. These are the images, both the CT and the MRI image. You can see the C4 that's toppling of the C4 vertebra over the C5. Though despite the high grade of injury that we can see, luckily for her, and she still had intact neurology other than the persistent pain that she had. And that was because in her own case, beyond the facetal dislocation, she also had associated pedicular fracture. So there was functional decompression of the cord, which was why neurology was preserved in this case. And so she was admitted and worked up for surgery. The surgery done was a 360 reduction and fixation of the cervical spine. We placed down traction to help reduce the dislocation. So the initial approach was anteriorly, where we did anterior discectomy. Thereafter, the wound was packed, and then she was flipped prone. Posterior reduction of the facet was done, and instrumentation with lateral mass screws and rod. Thereafter, she was returned to the supine position to complete the anterior discectomy and then placement of PIC cage with anterior cervical plate and screws was done. This was the post-op radiograph of the lady after surgery. Neurology was preserved. Post-op event was uneventful. She was discharged on the 10th post-operative day with no neurologic deficits. This was a radiograph 1 year post-op with evidence of fusion at that level at C4, C5, with no evidence of any implant failure. This was a clinical picture. Anteriorly, we could be the incision of the scar of the anterior surgery is barely visible. However, posteriorly, we can just see a fine scar there posteriorly of the posterior surgery that was done in her. So, in wrapping up, spondyloptosis is usually caused by high energy trauma. Usually, it tends to occur more at the cervicothoracic junction. So, having seen it at C4, C5 is a bit rare. It's really uncommon. It tends to occur more at the junctional parts of the spine where there's transition from highly mobile to immobile segment of the spine. Usually patients, when they sustain this type of high energy trauma, usually they tend to present with complete spinal cord injury. However, in a few cases, just like the one I just presented, they may have partial or intact neurology. Like I said earlier, this tends to be commoner at the transition level at the cervicothoracic junction more than all other levels combined, and the treatment is usually operative. The approaches, if you look, when we look through literature, some have described doing this through just a single approach, either anterior or posterior, and in other instances, combined approach is required. Like in this instance, because of the delayed presentation, it will be difficult to do this with a singular approach. Usually, a combined approach is just the best way to get this fracture dislocation reduced and fixed. Traction, there's been some argument about traction, preoperative traction, whether there could be retropulsion of the disc material into the canal and causing cord injury. This was the opinion of Menko et al. In his paper published in 2004. However, Tumialan et al. Had reported in 2009 that usually there's functional decompression of the spinal canal, and so with traction, the risk of having retropulsion of the disc into the canal and causing further cord compression is usually low in this instance, and so traction can be safely applied prior to surgery. And so, as I wrap up, subaxial cervical spondyloptosis is relatively rare. The clinical presentation could range from being neurologically intact to outright quadriplegia, and it's important to avoid the armamentarium and the wherewithal to manage this kind of patients. Most importantly, prevention is what's best done here. In this instance, the lady had been at a peripheral hospital where, for whatever reason, they couldn't manage it and didn't refer, and she didn't turn up until 2 months after the injury. Possibly if she had presented earlier, we may not have had to do so much, but thankfully we had a good outcome of this fixation of our management. And these are my references for this presentation. Thank you all, and questions and comments are welcome. Thank you.
Thank you, Dr. Toulouse. I am really amazed at the way this case has been managed. Congratulations to you at first. I have done a spine fellowship, though I'm not a practicing spine surgeon anymore. But I have a couple of questions for you. The first question is, what sort of a table were you using? Did you have a table where you can flip the table around, or do you need to turn the patient around? In which case it is difficult to do that when the spine is an unstable way. That is the first question. And second is, when you do the anterior, posterior, anterior, do you close the anterior wound and then open it again?
Oh, okay. Right. So we don't
Enlighten
have
us regarding the same. And you can stop your sharing now.
yeah. Oh, okay. Let me stop the sharing. Right. So I don't have the benefit of the table that you can swing the patient around, which makes it easier to do circumferential approaches to the spine without having to move the patient around. I don't have that benefit. So after the anterior approach, the discectomy, we had to transfer the patient to the trolley and then turn the patient around prone to do the posterior approach and then get the patient back on the trolley again before the position. So we had to do, it was a couple of turns and then a couple of changes, scrubbing in and out, changing drapes and gowns severally to minimize any incidence of infection or break-in asepsis. So we have to do that severally to do this case. Then so for the anterior surgery, so we just packed the wound and tagged it. Wasn't a complete closure because I knew I was going to go back to the anterior to complete. It was just to do anterior release to make the posterior reduction easier. That was what was done. So the wound was not closed. Definitive closure was not done for the anterior wound. We were just tagging. We went posterior. The posterior surgery after the reduction and placement of the screws and rod, definitive closure was done, and then we returned anterior to complete the anterior surgery.
Right. Thank you. Thank you so much. Any other questions? Right. So I think you're the only spine surgeon in this group. Rest all are prolific trauma surgeons. Thank you so much, Dr. Toulouse.
Right. Thank you.
We move on to the next case, and it is to be presented by Dr. Ghassan Salame, and it is infected non-union bone defect and deformity management using the Salame Fix external hinge fixation system. Over to you, Dr. Ghassan.
Good day, everybody. So it's my pleasure to present my case of non-union. I hope we can see this is a fracture, 23 years old man. After fracture and repeated several surgeries, was first applied a plate, but was failed and was osteomyelitis. And then the plate was removed and the bone was done curettage. A large amount of bone was corrected and removed. And we see there was applied an external fixator and there's a deformity. So the patient came with this situation. So what I did is osteotomy of the bone ends and making alignment of the femur. So the bone sticks end to end in perfect alignment, and applied my external fixator Salami Fix #1, which I modified for femur and tibia lengthening and deformity correction. And we can see here, after the frame was applied, we waited for the first time for union at the non-union place, and I made an osteotomy of the end of the femur and start to make lengthening and bone transfer. So second stage was lengthening at the end of femur using the same fixator of Salami Fix #1 after I modified the hinges. We can see here using my compact design for external hinge fixation system, Salamifix 1, which I modified for lengthening and deformity correction. And this fixator can work on femur or tibia or on the hand. So the patient had two problems of bone defect and non-union on the hand and femur. We can see here the fixator, how it shows in outside, and we can see on the X-ray the alignment and lengthening around 9 centimeters lengthening. We can see alignment, stability, and full weight bearing of the fixator. We can see here on the X-ray consolidation, alignment, full weight bearing, stability, and mobility of the patient is very important. So that the patient can walk, exercise, full weight bearing system. The other problem of this patient was of the hand. Also, he was had a trauma on the hand. He had a plate fixation, and later he had osteomyelitis and bone loose. So what I did is removing the bone, infected bone, application of my fixator Salamfix #1 on the forearm, and making a bone transport and replace the whole bone defect gradually. And we can see on the X-rays the stages from beginning and during, lengthening, and until consolidation. We can see consolidation of radial bone here and union at the fracture place. And the fixator is small. This is my fixator, Salamfix #1, which I modified here for this one case of cosmetic limb lengthening of both legs. We can see how it's suitable system. Conclusions: the Salamifix external fixation hinge system is a small arc, 3-dimension external hinge destruction fixation system, enabling simultaneous lengthening and correction of axial deviations, providing high stability, mobility, tolerance, and allows early weight bearing. And we can see here the WIPO award certificate for this design and the international patent of this design. And this system was published on the International Orthopaedics Journal. So you can see it on this journal. So this is my case, which I wanted to present, and would like to thank you for your attentions. And please, if you have any questions.
Thank you, Dr. Ghassan. This is a wonderful, what I call as a tweak or a modification. And I really, really like it. I'm sure this has a big role to play, especially in pediatric orthopedics and deformity correction. With that, I would request you to kindly stop sharing, and we'll open this session for discussion and questions. If you can stop sharing your.
No.
I have a question.
Okay.
Hello?
Yes.
Yes, Dr. Ghassan.
Yes.
My question is there a limitation for this external fixator, or like in terms of bones and age limit? Can we use for kids? Can we use for adults? And can we use for all deformities? Any limitation?
Limitation of the external fixation on there are no limitation of the use of the external fixation of salamitics, so we can use it on every cases, which deformity and which the trauma or any case we can use it. So no any limitation. It can be modified. The system can be modified to use in any case of a trauma or deformity cases.
Yeah. Dr. Ghassan, can you stop sharing your screen because we are not able to see the
Stop
participant.
sharing. Okay.
Yes.
Okay. Now?
Yeah.
Okay.
Thank you. Thank you.
Yes, please.
Yes. Any other comments from any of the other dignitaries on stage, on the dais, on the platform?
I think one challenge for low-income countries is the cost of the implants. I'm sure some parts of India are the same as in Africa. So I was wondering if Dr. Ghassan's implants are way affordable compared to orthofix and European standards, so that we can use for our trauma cases.
So what the question is? I didn't understand.
I think he wants to know if it is affordable. The cost of
implant.
Yeah,
cost of implant.
now the system is I only who is using it, but I'm waiting for a company to produce it. Then we can share it internationally. But for the moment, it's my own use.
Great.
Dr. Ghassan, in your experience, the union and lengthening at the same time, how long does it take for the union to occur and the lengthening? Is there any difference in the durations?
Yeah, union can take, in these cases, delayed union can take from 4 to 6 months, and lengthening depends of the amount of lengthening. So the lengthening, we do 1 millimeter per day, but consolidation time can take around 1 to 2 months for every centimeters. So duration of treatment maybe take sometimes 1 year. It depends of the amount of lengthening. But the
Great.
patient can walk from first day, can walk with full weight bearing on the system and can exercise.
Wonderful. Wonderful. Thank you, Dr. Ghassan. Wonderful innovation.
Yes.
Congratulations to you. Thank you so much for presenting it
Thank
here
you.
on this platform. Thank you. We move to the next presenter, and that is Dr. Elion Diouf, and he is going to be speaking on open fracture heel stage. So over to you, Dr. Elion. Please go ahead.
Hello, Dr. Kenny. Hello, all the faculty who are here. Thank you very much for this invitation to share one of very important and common case we got sometimes in our country. So, before starting, I think that although I'm the only one from in the francophone, that's why my English sometimes will be created by Dr. Sofiane. So I come from in Senegal. For some people who don't know Senegal, Senegal is one of the country in the West Africa. I think that a lot of people know us about football because we have a very good and a very big team of football team. Sometimes we have some problem, but it's very common for all team. It's very good country, very nice country. We have peace here. We have a lot of contrast of the environment of the area. We have the sea, we have mangrove, we have all the things. But it's a very nice country to visit for your next travel. I invite you for you all. So the case we have we want to share this morning is this is a 30-year-old female patient with no reported medical and surgical history, a non-alcoholic and non-smoker who was involved in a road traffic incident, resulting in a tip 3 gusio open fracture of both lower leg bones. Initially, treatment with debridement pining and external fixation was performed. The outcome is not ideal, as will be seen in the following slides. So, in the picture, on the 28th day, on the bed sore with necrosis and exposure of the tibia, in the slide, the fixator is in place. Indeed, faced with the situation, we remain perplexed about what to do. Many options are available to us, especially in reconstruction or even coverage. Overall, the assembly was satisfactory. The only challenge here was the reconstruction. The fixation is good, I think, in the slide. Mining, what we have to do is the main question. Pay very careful attention to the option we use because it will be decisive in the rest of the game. Not just advancing the pawns to move, but moving in the right direction of the game will lead us to the expected results. So we have some supplementary assessment to do before additional examination are necessary, namely a bacteriological assessment, an infectious assessment, as well as good probabilistic antibiotic therapy. In the picture, the simplest option, and I think common to quite a few surgeons, was this, namely directed healing while leaving the external fixator in place. Thus we do, I think that in our practice for the most of surgeons. What is most of surgeon? The kin graph is corrected out after good budding, of course, by moving the external fixator. 3 months day 11. And so what's the next? In the picture, you see the graft is not very good, the external fixation. And when we replace the fixation, we have a replacement of the fragment. So what's next? Rejection of part of the graft and the bone exposed again. This displacement of the screws also led to a loss of bone reduction that we have in 1 year and 5 months after. So in this picture, you see again very amorphous anterior surface, the post-scan quality. It's in 1 year and in 5 months. On the radio, you see this the fixation here. On the radio, we lightening this like just this white witness to a ceratosis. This is not the time to give up. After a game of case, then we can judge to be have lost because it's all in the strategy. Hence the art of war, and these losses of substances are our fight of war. And we must constantly anticipate strategies until we reach our main goal, which is complete healing of the skin and bones. This is the overall presentation of the leg with this unsightly scar. Our option was this cross leg and external fixator modification and bacteriological sampling on 28/11. So 1 month and 1 year and more and a half later. Here we see in the X-ray the external fixator in place and the bone in the right way, I think, and one pinch in the fibula. Flap winning was done with zinc skin graft on the donor side. We can see in this picture with the progress first and after the salvage, the flap, the winning. The final result shows good cushioning after 2 years and 3 months. We have a lateral, posterolateral approach here for this surgery. The final result shows good cushioning healing, the bone completely covered and the leg properly aligned. An entire bacterial perineal graft 2 years later, very good bone healing. We can see this in the picture. I think that for this kind of patient, you have to take your time. If you take 1 year or 2 years, I think that we have to take all time. We have nothing to lose if we spend 1 or 2 or even 3 or to try to heal this kind of bone. So we do this graft, intertibiopeteral graft and bone graft on the 25 and 9 at the 9 month of weaning in the front position. So we can see this, the patient here healing. He's working. Overall, the end results is this good healing. The patient is initially able to move slowly but surely. The lesson I learned from this situation is that it is necessary to immediately go for reconstructive surgery covering the ipsilateral flap if the quality of the soft tissue allows it. Otherwise, do a cross leg and secondarily reinforce it with tibioperoneal graft bone if this consolidation is timid or incomplete. The rest will be covered by rehabilitation. We see this patient who work slowly because he is afraid to to have his tibia broken again. So overall, the end result is this. Okay, but we have some key message: early coverage of soft tissue. I think that we can do this before the 7 days. If late, let it heal and improve coverage. Advantage of antibiotic pellets is proved in our practice. So thank you. I think that I'm not very long. I'm very short for the presentation. Thank you,
Thank
Dr.
you. Thank you, Dr. Alion. If you can stop sharing now. So let me first congratulate you on getting out a unique solution to this particular problem, trying to convert the two bone leg into a one bone leg by, getting a cross union, which is out of box thought. So congratulations to you on managing this case with whatever resources and, whatever condition the patient came in. And may I now put up this case for discussion? So I think Dr. Sufyan is here and he wants to express.
Yes, thank you very much. And I would like to congratulate my friend from Senegal for this presentation and to rise up this technique from this French-speaking word, because it is relatively common, this technique in the 1970s. I used it before in my early stages with orthopedic surgery. And the cross leg, because if Eric is all still with us in the meeting, Tortosa, the cross leg flap is could be a salvage in some situation when you are not an expert in flaps. The cross leg is very easy. Nevertheless, the cross leg is a thief flap. He's stealing blood from the side, because you bring a flap which is vascularized by the donor side, but once the flap you separate, you cut it, then you will take the blood from the donor side, and it became an inconvenience for the healing of the bone. It means it is only soft tissue solution. And the intertibioperoneal technique, which I suggest to you, Dr. Diab, next time, for this technique, normally we need a healed fibula, because your fibula was not healed and you just put a pin for the access of the fibula, but you can go in a zone which is virgin, there is no scars on it and it. And second is you can do a long plate on the fibula and to put 4 screws up and down from fibula to the tibia, and then you have stable position and you can graft beneath the intertibioperoneal flap and you have a very good solution. I'm happy that you raised these two techniques from the French-speaking world. Thank you very much.
Thank you.
Thank you. Any other comments from any of the other speakers, faculty? I think very well done in the sort of resources and the condition in which the patient came to you. Thank you so much, Dr. Alion. And we move on to the next presenter, that is Dr. Sofian Khalil. So would you like to present from your computer and share the screen? Absolutely.
Are you okay like that? Or it is full screen or not full screen?
Yes, not full. Yeah, now full screen. Yes.
Now full screen. Okay, thanks again for to give me this opportunity to participate in this trauma forum, which is very, very interesting. And I think it's a very good opportunity to present our cases where we have some challenges. I won't be very long because already Eric gave a lot of theoretical approaches for this technique, and I will present two cases, special cases for non-union of femur, septic non-union. This patient, he is, I think, 50 years old, had 3 previous surgeries with plating of the femur, infected femur, and each time they shorten a little bit the femur and put a new plate. She shortened a new plate, and he came to me with a 6 centimeter shortening. And this patient, the challenges when you receive patients from outside the country, you have 2 challenges. You have financial constraint and you have time constraint. You cannot leave the patient with his follow-up for 6 months or 8 months because he's coming to your country to solve his problems. Since he doesn't have resources in his country, then this is, I think, a big challenge for us when you receive some patients from outside the country. Then how to deal with these centimeter shortening? I think the first step was to go to remove the plate and to do a masculate technique. And for this masculate technique, we used monorail external fixator, which is, and the graft was with fibula graft and chips from the iliac crest. Because after resecting the bone, the infected bone, we have 13 centimeters bone loss. And with the 13 centimeters bone loss, it is very difficult when you don't have a bone bank, you don't have, patient don't have resources to have a lot of bone glass fibers and so on. And you are in an infected site because this person came with a history of infection of 3 years or 4 years, I think, with different surgeries and so on. But I will ask the faculty attending now the meeting if in the messages they can give me an idea by message, send you a message, give me 15 seconds or 30 seconds to send my message to Swapnil. What is your proposal at this stage? You have these patients with 13 centimeters bone loss, and the CRP is not normal at almost. It is the CRP is at 20, ESR was at 50, and with this bone loss, what is your suggestion? Would you please the faculty send your suggestion to Swapnil, and we will discuss it later on to see what are your suggestions. Please put your suggestion by message to Swapnil. 10 seconds, just put your suggestion to Swapnil. Because it is very, very challenging. It's very challenging, 13 centimeters bone loss for patients who is not Tunisian. He has to come his country with a final solution. Then I will tell you what I've done. Because I don't have a lot of solutions to give native bone and to give a stable fixation for these patients. Then what I have done, this is how was the external fixator. I removed the external fixator. I curated the canal of the different pins and so on, and cleaned everything. Okay. And I tried to clean all the tracts, the pin tracts, which was infected, and with washing all the pin tracts. And then I reamed around the fibula. I left the length of the femur, and I started to ream with 6 millimeters until I arrived to 13 millimeters. And I brought all the bone which was around the fractures, and I put a nail, long gamma nail, because since I presented to a lot of colleagues before doing it in AO sessions and so on, and a lot of them went even to do an amputation because after a lot of surgeries, infected and so on, there is no. But I took my courage with the 2 hands, as I say, and I have put a nail, and I don't regret it because this is the result at 1 year. He healed almost. We have bone around, and the patient says after 1 week, which is walking without any aid. This is my first case. Then stability for me, because I'm a fellow of Mascale, and here always it's stability and respect of the basic rules of healing are very, very important. Stable fracture and stability is leading to infection. Internal fixation help in some borderline cases. It's a borderline case. It's not regular case. It's a borderline case, very difficult case. Okay, this is my take-home message for my first case. I show you the second case. It is similar conditions almost. This lady, 50 years old, with previous 9 previous surgeries with septic non-union. And you see, she doesn't have any iliac wing anymore. They took all the iliac wing in different surgeries of grafting, and she arrived with limping, and she is very obese with 9 previous surgery. As usual, I am very muscular, and this is the situation of the femur. No more iliac crest, non-union. Then I have done an external fixation, lengthening, and muscular technique. Why? Because it is the only option to clean and to have a good receptive zone. Even if she had the fibers, the zone around the fractures was very fibrotic. Even the muscle was very weak. But the challenge here is the proximal femur is very short. But the proximal fragment of the femur is very short. For which type of instrumentation, what type of devices that will give you stability in such fracture? Because when you have 6 centimeters of bone loss and very big shearing forces in the proximal femur, it will be very, very difficult to stabilize this fracture. And this is why she already had 9 surgery. Now we have 8 centimeters bone loss. We are at 140 days, 45 days after the muscular technique. The skin is healed. Everything is okay. The test labs are negative. And the challenge here is what type of fixation will you do for these patients with 8 centimeters? She is very obese. This is what I have done. I have done bone graft for the 8 centimeters and with hook plate over a gamma nail. Why? Because it is the only way that you can have stable fixation of the proximal front. Because the various shearing forces, if you will put a gamma nail, it will break. Definitely under the screw, when you have very short proximal femur and large bone gap underneath, if you don't fix the great trochanter, the gamma nail will break. And that's why I have done this fixation with long hook plate, and it is relative stability. I maintain the AO principles of relative stability to have the healing of the fracture. And this is the result of the patient. And this is 2 weeks after surgery. And you see the type of scar that she has, and how easy it was for her to walk just very early, since the strut where the fixation was very good. I think biology is important, but nothing without biomechanics. And proximal femur is different from the physical and distal femur. It is very, very important to try to have a very good fixation for proximal bone loss in proximal femur. Thank you very much.
Thank you so much, Dr. Sufyan. Some really innovative thought process, but always following the AO principles. And that is why I think you have succeeded, because you have, though there is no defined mechanism to treat every fracture, but there are principles and you followed them to the T. I congratulate you.
I always fix to the AO. I'm fan of AO. I'm in AO for more than 20 years now, and I think for AO, when you stick to the principles, you cannot get in a mess.
Excellent. Thank you. Now, if you can stop sharing, I can take a couple of comments or thoughts from the other faculty.
How to stop sharing?
Yeah. So, thoughts of faculty on these two cases? I think Dr. Matthias would like to speak.
Yeah.
How many suggestions on the messages?
Thanks,
there
Sufyan,
are
for this
quite a few.
nice
Quite a
case.
few.
Yes, go ahead.
So what is your time frame or your considerations to go with the internal fixation after having a son with osteomyelitis? Yeah. Do you? I see you put the cement with antibiotics there. How long you leave that there, and do you have any examinations that you take before going with the internal fixation?
Between 6 to 8 months. Even that masculine now leaves them even for 4 weeks, not 6 to 8 weeks. Masculine now sometimes doesn't put any antibiotic in cement, and for them it is only to put a spacer. And if you have a very good coverage of muscle, you can give the antibiotics for oral or other. Then for me it is 4 to 6 weeks. For me, it is 4 to 6 weeks. When you see the test labs are decreasing gradually, it means you are on a good way. But I think it is very difficult for me to wait until 3 months or more, or until you have test lab which has negative 100%. And I discussed this point with Maskely himself, and say it is very difficult to have a CRP and ESR normal at 4 to 6 weeks. But even they are subnormal, okay, you consider in a good position. The only point that you have when you take off your spacer, you have a good membrane. You shouldn't have a debris or very inflammatory membrane. If the membrane is very inflammatory, it is not good, it's not continuous, okay, you have to remove everything and to go back. Second point, when I put my cement, I do never put the bulk like in one piece. But when we put cement, I cut it with the blade in small pieces. Then I remove it easily to not destroy the membrane when you be tough with to get off your cement.
Great case. Any other comments before we move on to the next presenter?
Yeah. How about using the artificial bone graft mixed with the own bone graft?
I almost never use artificial bone graft. Very rare, very rare, very rare.
Thank you, Dr. Sufyan. Wonderful
very
case.
much.
And we move on to the next case, and this is by Dr. Yasin Bharkar, and this is infected open fracture tibia managed by Mascare. So one more Mascare. Dr. Bharkar, can you just start presenting?
Hello, can you hear me?
Yes, loud and clear. Please go ahead.
Well, thank you very much for this opportunity to present my case. This topic has already been covered by my colleagues, and they were really very great lecturers. My name is Yasin Barkat. I'm from Somalia, and I am sharing with the muscular technique that we manage normally. Mainly, we use this to cover the bone defects because in our country there are very limited surgeons who can perform the bone transportation, and we do not have that much um, implants and facilities here. So I believe and I support that muscular technique is one of the best techniques to cover bone defects. I will really do some introduction of the technique and some indication is the case presentation, and then some of its pitfall complications, and then how we can do the procedure and the surgery that I see or I believe is the best way, already mentioned by my colleagues. The principle is, as we can see from here, is that the muscular technique, the defect should be prepared and debrided. And when it's debrided and prepared and it's infection free, then you can put a spacer. When you put a spacer, you have to wait 4 to 6 weeks the membrane to form, and then inside the membrane you place your graft. So the main concept is preserving that graft, putting that membrane a graft volume that is enough, and the membrane separates the graft from the hostile scar tissue and limits resorption. Muscular technique is reproducible, and it uses a widely available implants, and same principle is that are simple to follow. It's mainly used for the bonus that are due to any reason, like a septic non-union. When you, it also not only that it helps the bonus, but it also helps treating the infection. After tumor resection, muscular technique is a very good option, and it's also an alternative to the bone transport techniques. My case that I want to present to you here is a 20-year-old male who had a gunshot wound in a remote area. These patients usually present a long way after the injury. They are usually infected. According to the how the wound was managed, we classified it as Costello type 2, but he presented in our clinic 8 months after the fracture, and there was the wound was infected and there was a discharge. So the first stage is to do debridement and take a culture and antibiotic sensitivity, and it's very critical. Even the first stage of the musculet, you have to get a very good stabilization. We have seen a lot of patients that we put the spacer and we neglect or ignore the stabilization at that stage because it's not definitive. But the result is sometimes the result is that the procedure does not work, because if the fracture is not stable, there's a lot of mobility, dead space forms, and infection does not go away easily. Or the membrane itself, because of lack of stability, it gets disrupted during the first stage. When you stabilize, then you can insert your spacer. And one of the critical things is the soft tissue cover. As already mentioned, it is very critical and it's a challenging step. Our case, after we did debridement and the culture, we stabilized it and used it one big antibiotic cement in that spacer. It has failed ones, because I believe it was not stable enough, the first stage. So the infection did not disappear in 4 weeks, even after antibiotic sensitivity, cultural sensitivity, and those steps. When the antibiotic was stopped, 6 weeks later, the patient has started again, and there was a discharge. There was still fistula. So we had to repeat the debridement and insert a new antibiotic cement again. And instead of 6 weeks, it took us 12 weeks to eradicate the infection. My point is that the first stage should be repeated as much as you can until your infection gets eradicated. The timing between the stages, it's 2 to 4 weeks membrane matures and forms after you insert your spacer. After 4 to 8 weeks, the biological big window in which the membrane is active, but it's recommended to do the fixation 6 weeks after stage 1. So clinical stage 2 is mainly performed after 6 weeks. Despite some articles I have seen mentioning that the biological activity is very big as early as 4 weeks. When you are performing the second stage, it's really extremely important to preserve the membrane, not to damage it, and to keep its integrity. Till it like a periosteum. You do not need to excise it unless you suspect could be a remaining of infection, or if it's non-viable. So you have to keep the membrane, because it is the bed is where the graft is going to survive. This is always patient postoperatively. We have done the double plating. The tibia blade from the lateral was open. After we inserted the fibula graft and ilia graft, we have and stabilized it from the posterolateral blade. Then we inserted a T-plate, which was a minimal invasive, because the soft tissue is very critical in this area. We have just opened a small window near the knee and another window in the distal to stabilize the grafts. This is the patient. It's only, this was, I think, 1 month before. This is after 3 months of the surgery, and the patient started to walk with a weight bearing, and he is improving. I believe that there is a significant callus around the fracture site, and there was no any signs of infection. There was no any signs of tenderness or pain, and any indication is that there is a risk of non-union. This is one of our cases. So I want to mention that the fixation of the second stage is also extremely important. Whatever you use, whether you use a plate or whether you use a frame, the stability, the mechanical stability is really extremely important. The soft tissue is another one of the main challenges that muscular faces, usually an open fracture, and the tibia is especially because of its lack of a good soft tissue envelope. So we have to keep an eye it, and because the soft tissue it is the envelope that supporting the membrane. The membrane cannot form if there's an open, and if there's an exposed bone, tendon, or implant or spacer is exposed, then it needs a coverage, and that coverage should be blended as early as possible. Another, you have to debride first, cover early, and when the wound is clean, you choose local, regional, or free flap. After that, you can go to your second stage. You do not need to rush to stage 2 if you have a marginal or a suspected soft tissue. The red flags are that you cannot go to second stage is persistent drainage. If your fracture, I am talking about the first stage. If your first stage is, fixation looks unstable, if there's a large dead space or hematoma, some challenges that we face when we use musculate include that the infection sometimes persists. So you have to repeat your debridement and spacer to eradicate the infection. Some infections, bacteria are really challenging to eradicate, so you have to give it its time. Non-union sometimes occurs even after the muscular technique. So you can repeat again for another grafting, or sometimes graft resorption occurs, and this is mainly because that you have damaged the membrane during the second stage. Mechanical failure of the fracture occurs if you do not second stage fixation is not stable. Soft tissue breakdown, FN of the second stage, can occur, and sometimes it's one of it has a donor site morbidity, which I never see, but it has to be mentioned. Surgical tips, in order to prevent the complications that I have mentioned, are you have to make the spacer slightly larger than the defect. And you have to overlap the spacer over the bone edges to prevent membrane collapse. You need to use stable fixation from stage 1. And you do not need to graft if you suspect that there's still an active infection. Another one is you do not remove the membrane unless it's infected or non-viable. And when you are doing your grafting, you can use a fibula graft as much as you can to fill the cavity, or with or without the vanilla graft. So muscular technique is really uses a familiar principle or trauma principle, which is debridement, cement fixation, and bone grafting. There are some resource constraints when it comes to the other methods. So it still has some implant and fixation available. The quality is always whatever you can reach with the fixation, with the stability you can use with the musculate. Microbiology, antibiotics, and follow-up reliability. It is also very important to give an eye on it. And access to plastic surgery, needing of RI, harvesting, and blood bank and rehabilitation are some challenges that face it in resource-limited areas. You have to prioritize to walk out and clear the infection, and you have to have a clear stage 2 readiness checklist before you start the second stage. This is my summary that musculate is a biological reconstruction which is very important, and that stability is really important even from the stage 1, and you need to take care your induced membrane and vascular biological activities before starting the second stage. Autologous graft volume and mechanical stability also determines the graft survival. And persistent infection, poor soft tissue, and instability are the common preventable failures. Thank you so much.
Thank you very much, Dr. Yasin. That was indeed a wonderful talk. It's a wonderful lecture. You can stop sharing. And one or two comments on the experience of Mascale, or anybody else would like to, say something about this technique. It would be wonderful. So a lot of discussion on Mascale technique. And any of the other faculty have any thoughts on this? Please share it. In the meanwhile, you can stop sharing your screen. Anyone with any thoughts? I think it is a wonderfully done and managed case, and the principles have been shown so very clearly. Thank you so very much for this wonderful presentation, and also the beautiful PowerPoint which you have made. Actually, it was very nicely made.
Thank you so
Thank you.
much.
No,
Thank you.
I totally agree. I think this muscular technique that's been discussed, and now there are 4 or 5, maybe more cases have been shown, and certainly work does wonders. And once you can master this technique, certainly will help a lot of your patients, particularly in the low income and low middle income countries. The cost is a major concern.
Absolutely. Absolutely. Thank you, Dr. Yasin. We move on to the next speaker. That
Sorry,
is the
Tommy, one brief comment.
yes,
But
yes.
you can combine techniques. So if you can do a masculate and a small transport, you can reduce the gap of bone that you need to cover. So or you can shorten a little and do masculate. So it's not that you have to use one technique only. Sometimes you can mix techniques in order to achieve a better result in a shorter period. Okay. Thanks. That's
Absolutely. Thank
Totally
you.
agree. Totally agree. Yeah.
Thank you. So we move on to Dr. Said Omar and his case on salvage plating for femoral shaft non-union with a broken intramedullary nail. Please go ahead,
Good
Dr. Said.
afternoon. Yeah. Good afternoon, good evening, everyone. Thank you, Dr. Swamnil, for the invitation. I think we are tired about musculate and complex fractures. I will present a simple case, but in terms of the resources I had and the challenges in this case is the reason that I'm sharing. So this case was initially managed by my colleague, who I think is also in the Zoom meeting with me. And then he presented to me after 14 months of his initial surgery in a remote area. I was doing a surgical camp in that city. It's about 250 kilometers from the area that I am now, the capital of Somalia. And then he was a police officer. He was not able to travel by air due to financial issue, and he could not travel by land due to security issues. So I had to do something to solve his issue. So consider my limitations when analyzing and criticizing my decision making. Is my audio clear?
Yes, it's a little low. You can speak a little louder.
Okay, let me try. So my name is Said Omar. I'm the national delegate of CICOT. I'm a general orthopedic surgeon, but I'm also interested in oncology. So the patient is a young police officer, 30 years old. He sustained the injury due to gunshot wound, and his injury was gastilla one, and it was not that large actually. And his past medical history was not remarkable, except that he was an active smoker, which is quite common in those with in the military or the police. So when presenting in the emergency room, he received standard resuscitation care, and he was taken to the OT for irrigation and debridement. Antibiotics was given, as well as other supportive care, including TT, and he was put in a back slab. So it's common in here to use back slab or external fixator, because sometimes if we have to do the surgery and with intramedullary nailing or plating, we prefer to use back slab because of reducing the cost of the external fixator and cost of the anesthesia. So unfortunately, I don't have the clinical picture of the wound and the pre-op X-ray, but this is the immediate post-op X-ray of the patient. We all agree that femoral shaft fractures are managed with intramedullary nailing. So he received the standard of care for fixation of this fracture, and he had some comminution at the fracture site, as you can also see some fragmentation of the bullet. So this was the immediate post-op X-ray, and the patient was coming for the follow-up until and we removed the stitch, and his post-operative immediate post-op care was uneventful, but he disappeared after the removal of the stitch. And then after the surgery, he was told to use the walker and to protect for protected weight bearing, and because of the defect to avoid fatigue of the implant or risk of implant failure in the initial period. So he was mobilizing with a walker, and then he disappeared, and then he came back after 14 months while I was in another city. So this police officer was from another place, about 250 kilometers away from us. So he came back with a pain in the thigh and without history of apparent trauma. So we did an X-ray and we found that the nail was broken and he had deformity, and one of the proximal distal screw was also broken. So we discussed the patient. He was a smoker. The fracture could not heal. As you can see, there is a defect in the anterolateral aspect of the shaft of the femur, and he was not compliant. He said after 1 month he was using a cane, and he went back to his routine. But there is also some callus in the posterior border of the shaft, posterior cortex of the femur, as you can see from the right X-ray, the lateral X-ray. So we decided to remove the nail and to fix the fracture and bone graft. So as you have seen the previous X-ray, there was a defect. So we discussed the patient the need of bone grafting. And we all agree that femoral shaft fractures are managed with nail, but there is no universally accepted or agreed procedure for extracting a broken nail. So one of the challenges we have was the nail removal. So we incision the patient in lateral. Through the same previous incision on the lateral aspect of the femoral shaft, we exposed the femoral shaft, and then we completed the broken nail by using the hacksaw. Actually, the osteotome or the electrical saw could not work for us, so we prepared this hacksaw and we removed the handle, and then we tried several times to complete the breakage of the nail. And then we extracted we removed the distal 2 screws, and then by using a ronger, we grasp the proximal aspect of the distal part of the nail, removed, and then we remove the upper 2 screws and then extracted from the interior side. So this was one of the difficult part of the technique. And then once we removed, we debrided the wound. Actually, it was not infected. I didn't mention, but his CRB and ESR and neutrophil count were all within the normal limits. And intraoperatively, and we checked the wound, it was clean, and there was some fibrotic tissue, but there was no any signs of infection. So we didn't take any swab because in that city we had no microbiologist who could do the culture for us. So after the breathing and refreshing the edge of the wound, and we also reamed the ends of both fragments with a solid sign reamer, and then we took a bone graft from ipsilateral fibula, as you can see, this immediate post-op X-ray. So, and then we put that fibula, and then we had to plate. So one of the challenges I had in that area, we had no C-arm, and so we could not put a nail. And also, if we have to put a nail, it was also, we had a defect, so we have to use some form of other fixation to hold the fibula, and I could not get access to small mini fragment blade or to hold that fragment. So we fill the gap on the anterolateral aspect of the femur, we plated, and this is his recent X-ray. I saw this patient 3 days ago when I returned to the same area for another surgery. Alhamdulillah, he's well. There's some colors, and he is walking with one crutch, and he is being free. His knee is also good. He's not fully flexing the knee, but he is able to and flex and extend and for his daily activities. This is the last X-ray 4 months post-op, and this is a patient 4 days ago. I don't know if you can see the video. He's mobilizing with a walker.
Yes, we
With
can.
yeah. Okay. So my conclusion is that intramedullary nailing is the standard of care for femoral shaft fracture, but implant failure is also one of the rare complications. The incidence of nail breakage is about 1 to 5%, and there are some factors that I think have affected the outcome of this patient. One is a non-union, another is the defect, the initial defect at the fracture site, which has caused the implant to not able to load and the load of the weight of the limb. And some other factors that can affect the non-union is the smoking and the comminution of the fracture, some modifiable factors that can reduce the incidence of nail failure is the quality of the reduction, which was good for this case, and also the nail size, the nail diameter. So removal of broken nail is technically demanding, and it's more difficult if you don't have image intensifier or the right tools to extract the distal and proximal fragments. So as I said, the patient was smoking, which may have affected the delay of the union or the non-union, and we have also a loss of follow-up and difficulty of compliance in some of our patients. So the salvage strategy will depend on what you have and your local resource. Thank you.
Thank you very much. It was indeed a wonderfully presented case, Dr. Omar. And if you can stop sharing, then we'll open up the case for discussion. Just one comment from my side before I let Dr. Kulkarni speak. And a very good improvisation in the absence of SIAM, No SIAM is something which we cannot imagine in this world, but there are places where you do not have the resources. So you have really utilized your resources very well in taking up a challenging removal without a SIAM and then using an innovative technique. So I must congratulate you on this case. Thank you so much.
Yeah. Can I speak?
Yes,
Yeah.
sir.
This is a case of biology and biomechanics, which is very, very important. Both are very important. Biology and biomechanics. Here, there is the biomechanics is also disturbed and biology is also disturbed. So we need to have a very, very stable fixation, and biology should be respected. So that in this such cases, once you remove the intramedullary nailing, then you try to fix it nicely, and probably you may need some bone grafting or something, but biology should be respected. So biology and biomechanics is a combination. That is the very, very important in this point. Very good case. Thank you.
Great. Any other comments?
Saeed, excellent case presentation. Honestly, you would see more cases of non-union or failure with plates rather than a nail. And converting a nail into a plate and utilizing your technique and knowledge of the biology and stability, as Dr. Kulkarni rightly said, that there was problem both with the biology and with the stability in the first instance, and perhaps smoking is something we all know is a major hurdle in healing the fractures. So, and you address both things. I hope you warned the patient regarding smoking after your second stage, you're putting a plate on. Otherwise, could have failed as well, but very well done.
Great. Few quick comments before we go to the next case. First,
just a very quick comment. You are very fortunate that this patient is not very tall. The plate was a little bit short, and in the distal you had only 3 good fixation. The fourth screw was limit. Then try to put longer plates, then you will be in more safe zone.
Absolutely. Dr. Alio, your comment?
Just one thing. I want to congratulate my friend Said from Somalia. But for the next time, just to be sure that the nail is in the same quality with the screw. I see the first time the screw is broken before the nail, and it's a very important thing to take about biomechanical. It's very important for this case. I think that's why you have the failure for this first stage of your sentences. Thank you.
Absolutely. Thank you. We move on to the next case, and this is from Dr. Nadir Shah from India, which is limb salvage for lower limb compound fractures. Over to Dr. Nadir. If you can start sharing your screen. Dr. Nadir Shah. Dr. Nadir Shah.
Yeah, yes, sir. Yes, sir. Very much here. Hi, very good evening, sir.
Very good evening.
Am I audible and visible?
Yes, please go ahead.
Okay, yeah. Is my PowerPoint visible?
Yes.
Yeah. Okay. So very good evening for people from India and good morning or good afternoon to the rest of the world. This is Dr. Nadir Shah. At present, I am serving as the head of the department at Grand Government Medical College, Sir J.J. Group of Hospitals, Mumbai, India. So my topic today evening is limb salvage in a Justilo Anderson grade 3B open tibia fibula fracture. So why this case and why this case matters? During this evening, I have come across very complex cases and very complex and very well done treatment and modalities and everything. And this case, what I've come up is very simple, unlike my other colleagues. But yes, it will give a very good message. So the clinical challenge here in such kind of fractures is high energy. Open tibia fractures needs simultaneous management of bone, soft tissue, as well as reducing infection risks. So there are three triads, which I believe. The number one is preserving the life and the limb by early damage control, debridement, and by protecting systemic stability. The second one is to convert contamination to control by serial debridement, WAC, and culture-guided infection surveillances. And lastly, reconstruct in the right order, soft tissue coverage first, definitive skeletal fixation after wound safety should be the key. Now here we present a case of 42-year-old male with a high energy road traffic accident, August 1st week 2025. A patient was having a grade 3B open fracture tibia fibula with extensive soft tissue loss and gross contamination. The patient was presented to the casualty after 8 to 10 hours of the injury, and there was a mid-shaft tibia fracture with the proximal fibula fracture. Primary treatment goal was here to infection control, soft tissue coverage, and obviously limb salvage. So the core decision was to proceed with stage limb salvage using damage control orthopedics, WAC, flap coverage, and delayed definitive fixation. So this was the initial imaging and the wound assessment. You can see a mid-shaft tibia fibula fracture with an open contaminated wound. The key implications were to unstable bone require soft tissue defect, require serial flaps, and definitive fixation delayed with wound closure. So here is the strategy. The case was converted from a contaminated instability to a stable reconstruction to 5 deliberate stages. First one is injury, later debridement with external fixator. Second stage was for serial WAC plus debridement. Third stage was cross flap, and the fourth stage was delayed intramedullary nail. Treatment principle was not to rush with the definitive fixation in a contaminated grade 3B. First, secure skeletal alignment, infection control, and durable soft tissue cover. So this was the first step in which damage control orthopedics by early control of contamination and instability, urgent and wound debridement with provisional tibia external fixator with WAC was started for wound and bed optimization. Our first objective was to stabilize the limb without closing uncontaminated wound. And second was infection control and wound optimization. After WAC, granulation improved, but there was an exposure of a necrotic bone. So granulation alone was not enough. Exposure of necrotic bone required further bony and soft tissue debridement before coverage. So these were the cultures and which showed pseudomonas with a very broad spectrum of resistant of all antibiotics. So additional bony and soft tissue debridement with plastic surgery was planned for coverage. So this was stage 2. Again, repeated debridement for wound bed preparation. Necrotic bone still persisted. So second bone debridement was again performed and the necrotic bone was removed. So after that, soft tissue reconstruction was done by cross leg flap and wound control after wound control and healthy granulation. Approximately 3 months after the index debridement and external fixator, the definitive soft tissue coverage was performed with combination of ortho and plastic teams. This was very much possible because we ourselves in our hospital have an orthoplastic unit in the orthopedic department. We have 3 beds allocated for them so that we can work together. So wound control was achieved by healthy granulation was present and durable coverage was chosen before the definitive fixation. So what are the transition after the flap healing? So what is the interval? This is very important. The external fixator was removed, but till the pin tracks were settled down, we were not hurrying up for any definitive fixation. Once the flap healed, the fixator was removed and an above knee slab was applied until the pin tracks completely settled. So there is no rush for the implant, which is the main take-home message in this case. Definitive fixation was delayed until all wounds were healed. Bridge phase, which is temporary immobilization and protective alignment and flap. Definitive skeletal fixation. Now after everything was healed and no infection was there, we made it very, very sure. And close reduction interfixation with a tibia IM nail was done after wound healing and pin-tack recovery. Soft tissue safety confirmed before the implantation and intramedullary fixation restored stability and allowed progression towards rehabilitation. So this is a radiological X-ray after 4 months of the fixation. A stable fixation, healed soft tissue envelope enable the biological progress towards union. And this is the full weight bearing video of the patient post 4 months after internal fixation. A full weight bearing, comfortably walking, a favorable functional endpoint after grade 3B injury with the exposed tibia cortex and a infection rate. So what is the take-home message? A take-home message that you require stage of reconstruction by debridement and temporary stabilization first. Definitive implants only after soft tissue safety. Respect the wound biology, as Dr. GSK just mentioned. Most important, WAC is a bridge, which between the exposed and necrotic cortex still needs to be decisive after debridement and coverage. Use of orthoplastic team works early. Plastic surgery improved was a central once cortical exposure was persisted. Aim for function, just not fracture fixation, but the endpoint was comfortable full weight bearing with radiological healing progression. Thank you so very much. And this is JJ Hospital at Mumbai, India. And I with wholeheartedly welcome you all whenever we have some courses, we'll definitely. Thank you.
Thank you very much, Dr. Nadir. If you can stop sharing the screen. And a wonderfully shown case. I call this the textbook case, follow everything by the book. Very well done. So we'll take the comments of the other esteemed faculty here as to what are their thoughts on the case.
Yeah, it's amazing to see when you have all the facilities, you've got an orthoplastic available in the same unit, and you've got everything available, and you can plan and go as Dr. rightly said, a textbook kind of case management compared to what Eric showed us from Panama, where they were struggling with the plastic surgeon, or Syed showed from Somalia, and then the um, the difficult cases, all of them, what we are showing, I mean, are difficult cases and they are difficult to manage. We all face the same problem and we just have to work with the resources available to get the best for the patient. So well done, Dr. Nabe. Send me a textbook presentation. Thank you.
So this is all possible because of Grand Medical College. We have a different wards for orthopedics as well as plastic. To be very honest, it's on different buildings. So in the transit only there is so much of problems we realize. So it is 1.5 year back we have started this orthoplastic unit, which we have inspired from Ganga, Dr. Rajshekharan. And so we have what we have done. We could have a different ward. So we connected the ward with the plastic people, getting 4 beds all the time, so that the patient who requires orthoplastic both intervention can be admitted in those bed. So this is a small thing what we have done, and which is a very practical one. But yes, you should have a good bonding between the plastic surgeons and the orthopedic surgeons. That is
You're
better.
doing a great service for the community and the people you are serving there. So congrats for that.
Thank you, sir.
Thank you, Dr. Nadir.
Thank you, sir.
And we move on to the next presentation. And this is Dr. Narayan, unfortunately, had an issue with his internet because there was a tree which fell down near his building and he's not getting a good internet. So may I request Kulkarni sir, if sir is there online? Uh, GS Kulkarni sir, are you there? I think he may have just taken a short break.
Wait, Karan.
Yes, yes.
Sir, Mr. Kulkarni will be back. Dr. Kulkarni will be back in 5 minutes.
Okay, so do you want me to start the next case and then go to Dr. Kulkarni, if that's okay?
Yes, sir. Yes. No, he's here. He's here.
He's here. Okay, superb, superb. So before Dr. Kulkarni starts, let me tell you, he's the senior most orthopedic surgeon, practicing orthopedic surgeon in India. He is over 90 years old. I'm not sure what his exact age is, but sir will tell you. But he is still active in conferences, in teaching, in practice, in giving second opinions, and very, very enthusiastic even in these webinars. So I thank him from the bottom of my heart for agreeing to be here and spending this Sunday with us. Over to you, sir.
Thank you, Swapnil. Yeah. Fracture neck of femur and shaft femur. A 45-year-old man had a fall in the a year and a half back. He sustained fracture shaft femur and treated by a local surgeon by interlocking intramedullary nail. Since then, he had mild pain in the thigh and hip, but continued to work. Now, this is the preoperative X-rays, multifragmentary closed shaft fracture. And you can see the surgeon had done interlocking intramedullary nail, and this was in October 2019. And you can see 2 months later, still the patient had pain. So he went to the local orthopedic surgeon. At that time, there was no fracture neck of femur. See, you can see that there is no fracture neck femur. So he continued to work with thigh pain nearly for 1.5 years. In May 2021, while trying to walk, he could not walk. He was referred to us, but could not come as it happened in the corona period. There was no problem. There were a lot of problems to come to a bigger hospital and all that. He was admitted in our in June 2021. And on arrival on 16 June, there was fracture neck of femur. You can see that there is a fracture neck femur, and you can see that if you see that there is a straight nail, but the surgeon has not a straight nail is on the entry point is, I think, wrong. So on arrival, it found that there was a hypertrophic non-union and tenderness. There was tenderness of the thigh. So it's a case of we did CT scan of the right hip, which shows that there is a comminution and displacement of the right. So we did a metabolic workup. Patient was well-built farmer with no complaints whatsoever. Renal function, liver function studies were normal. Parathyroid, thyroid studies were normal. Diagnosed as displaced fracture neck of femur with non-union shaft femur. So the treatment plan was fixation with valgus osteotomy and retrograde nailing. No arthroplasty, of course. He is a 45-year-old healthy farmer. On table, we had anatomic reduction and decided to do fixation with a triangular construct instead of valgus osteotomy. These are the X-rays on day 1. Note there is an anatomical reduction and a triangular construction. This is a triangle construction. The superior screw passes through the threaded portion of the DHS. And it's a modified DHS, a locking DHS. And this is our modification of the DHS. So that was the first stage. And next day, we did retrograde nailing, but no bone grafting, as it was a hypertrophic non-union. This is the X-ray on day 1 as a second stage. So X-rays 4 months later, fracture appears to be uniting the neck femur. So also the X-ray shows shaft 4 months later. Six years after, on October 25, the X-ray showed nice union of the fracture neck of femur. Also, both fracture neck femur and shaft fracture united, healed well. There is no AVN. This is the full function back to his field works. So what is the triangle construct? Triangle construct is strongest of all construct, based on truss principle, an engineering marvel used in long bridges and tallest buildings. So Liver et al. From Canadian group were the first to suggest that triangle construct is the strongest construct. This was published in Journal of Trauma, JOT 2008. This is the triangle construct that Liver had done on a cadaveric bones. This is a new concept of fracture fixation, hitherto not used. We are using it for the first time for the fracture neck of femur. This was published in 2024. The recent updating is we had for 56 cases from 2019 to 2026, 7 years, 53 cases united, 94%. 2 had AVN, 1 failed, and 1 had a complication of triangle construct. This is another case. There's a 53-year-old lady with fractured neck femur. It united after few years, but there is a complication of triangle construct is that this was treated. She had a fall at home and she had peri-implant failure. This was treated with DHS and healed well, and she is walking well. Now, fracture neck femur heals only by primary healing and almost never by secondary healing, because the fracture neck femur periosteum, there is no cambium layer, callus formation, secondary healing is not possible. And hematoma is continuously washed away by synovial fluid. Synovial fluid itself is detrimental to healing, and there is a precarious blood supply. So, fracture neck femur needs absolute stability. Even mini micromotion disturbs healing, because thousands of cutting cones on both sides burrow into the opposite sides, and therefore the cutting cones. Now, any motion more than 0.1 millimeter or strain more than 2% disturbs the cutting cones, and non-union may occur in fracture neck femur. It's a delicate microscopic procedure. This is from Rockwood and Green, 10th edition. So in conclusion, a 1-month-old displaced fracture neck of femur secondary to 1.5-year-old shaft femur and non-union treated with triangle construct healed well, full function, and no AVN. So thank you.
Thank you very much, sir. Indeed, a very, very innovative technique. And before I go on to the others, may I congratulate you for publishing such a large series. I know you have one of the biggest private hospitals in India with a big orthopedic unit and all subspecialties. So congratulations. And just one question is, where in India is this available? Is it available with any of the manufacturers, common manufacturers?
Yes, in India, Nebula is the manufacturer. He is our manufacturing partner, and he is available, and you can contact him on Nebula, and he is available. But it is not, of course, generalized, not used, and it is not so popular as the technique is not difficult, but it is important that one should follow up the fracture neck femur case. It's a very difficult case to treat. One of the most important or the complex fracture is the fracture neck femur. We should, especially in the younger age group, less than fair. We don't use it after the age of 60. 60 after the age is arthroplasty. Before the age of 55, 60, one needs to stabilize, and fracture fixation is necessary, not arthroplasty.
Thank you, sir. Any other questions, comments from the other faculty?
Okay.
And just
Go on, Dr.
okay,
Yasir.
Dr. Thank you, Dr. Yasin. Dr. Kulkarni, thank you very much. Very interesting case. And I'm, first of all, I heard you're 90 plus. I wish I would be like you when I'm 90 and still working and practicing.
Oh,
so you've got years of experience, and we are learning from you. This construct, the type of plates you're using, I've not seen it, honestly. So, what are the material or what type of plates though you are incorporating with the DHS? And why not 60 plus? Why are you restricting only for the younger population? Why not using it? Because with a strong fixation, a 60-year in numbers could be a 40-year-old healthy individual.
Yeah, a good question. The arthroplasty gives excellent results. Hello? Yeah, arthroplasty gives excellent results compared to the fixation with after the age of 60. We have tried in fixation after the age of 60, but the failure rate is very high. So arthroplasty is very good, a good option. Of course, in 60 years old, it is better to do arthroplasty rather than fixation. So we have tried and stopped using fixation in after the age of 60. Of course, unless the patient is very fit and the DEXA scan and QCT, etc., is normal, then with the consent of the patient, we do fix the fixation, but it is not very common. Arthroplasty is better in after the age of 60 than fixation.
Thank you very much.
Thank you. Any other questions to
Okay,
Professor Kulkarni?
one more question. Thank you very much, Dr. Kulkarni. I am very happy, and Dr. Yasser Khan, to be sharing a screen with such experienced 90 plus surgeons. Thank you very much for your presentation. I would like to ask you, do you have any material available online or documented technique in order to learn the tips and tricks of this surgery? I believe it's really extremely important for the young patients to preserve the head of the femur and not to hurry perform a replacement surgery. So my question is, how can we learn it from the techniques and the tips? Thank you so much.
Yeah, what is the question?
LCVA journal, we have published LCVA journal.
Yeah, so he wants to learn techniques and tips for doing this surgery.
Yeah.
Where he can learn from it.
I would like to present in the YouTube this technique and each step-by-step fixation of the fracture neck femur. Step-by-step fixation we are putting in the YouTube, and I will send you the link for that.
Thank you so much.
Thank you. Please put it on the group, sir. We all want to learn from you.
Just one more question for Dr. Kulkarni. So for younger patients, you have stabilized a month-old fractured neck of femur, right? Where most you would say AVN is guaranteed 100%. How many cases actually the young patients had AVN in your case series?
Yeah, we had, I told you, complications are there in younger patients also. Because fracture neck femur is one of the worst fractures the human being can have. So we have to be very careful about complications also. I had showed you one case of complication, but having said that, reduction is very, very important. Once the reduction is achieved, then a stable fixation is very important, second point. And thirdly, I do not allow them to bear weight for 2 to 3 months or so that we follow up each case and then allow them to weight bearing, because weight bearing is very important. If they prematurely weight bear, then is likely to fail. So fracture neck femur is a very, very important fracture, especially in the younger age group, because arthroplasty in younger age group is little bit difficult, if not impossible. But that is what I say. Am I clear to you? Anyone to?
Yeah. No, thank you very much. Really appreciate that.
Thank you. We move on to the next presenter, and that is Dr. Shakir Kapadia. And he will be speaking on anticipating a problem in fracture humerus. Kapadia, sir, if you're here.
Yeah, Swapnil, I am not at present. I am not at home. I'm in some other function. So I will not be able to run the show. I mean, I'll not be able to run the slides. So I think Swapnil will have to help me there.
Yeah, just a minute. I will just check.
Swapnil, I want to show that our publication is available on YouTube. Our publication is there.
Sure. If you can just, sir, put up the
I will.
The link on the group. I am just trying to open Dr.
Injury.
presentation. Yes, injury journal.
Injury August 2024.
GSK pilot study.
GSK pilot studies.
Okay.
GSK pilot studies. You can get it on injury 2024.
Injury 2024. Right.
Yeah.
So just 1 minute before I am trying to open the presentation of Dr. Shakir.
जरा पंखो बंद कर. Yeah, Swapnil, you're good?
Yeah, just 1 second. I'm just trying to open your presentation here. Because I am actually on the iPad, so
Because I am not at home. I'm outside in another something. So I don't have my iPad. I don't have my laptop.
right. So I think what we can do is I'll try and open this while the next case is being going on. I'll try and open this on my laptop. We'll go to the next case, and I will, in the meanwhile, try and open it. So the next is Dr. Sachin Bhosle, right, sir? Is that correct?
Hello.
Yeah,
Am I audible?
Yeah, Dr. Sachin Bhosle, and fracture neck femur, well fixed by compression screw, DHS complicated by non-union and sub-implant stress fracture.
Yeah. I'll share my screen. Yeah, and I'll play that. Okay, so it's about a stubborn hip fracture. Actually, this case was a red flag right from the start. It was referred to me by my spine surgeon colleague. She was a 69-year-old lady with history of blood pressure and thyroid, BMI 30, and otherwise very active and mobile, used to do everything. A retired banker on thyroid and blood pressure tablet, had knee replacement few years back. No history of any fall. She had a hip pain during a session of physiotherapy, which was advised by her spine surgeon for radiculopathy. This is what she came to me with. We can see that it is a basal type of a fracture neck femur in a 69-year-old. Did look odd, so I did a MRI scan, and I also did a full bone metabolic workup for her, and then decided to treat her. So what to do? Considering the fit and active lifestyle, I chose to fix the fracture rather than replace it. Like I always do, fix such fractures, I reduce it on a fracture table. I pass 2 guide wires percutaneously. I pass 2 cannulated screws to compress the fracture. Then I take out the lower cancellous screw, pass the triple reamer, and put a 2-hole synthesized DHS, providing compression with a solid screw underneath and a smaller screw on the top. This is what was done, and on table I had certain problems here. So what problems did I have? Perhaps they can be seen looking at the X-ray that the fracture position is not perfect over here. So that's another zoomed in view of the fracture fixation. So what were the intraoperative problems? The guide wire went easily, but the bone was hard. Fracture could not be compressed well with the CC screws. DHS triple reamer was very hard to drill in, and DHS screw won't rotate, so I had to use a tap. And finally, the DHS screw went, and a 2-hole DHS plate was not available, so I had to use a 4-hole DHS plate. So, hoping that everything would follow fine, but 1 month later, we can see in this X-ray that there is a lucency at the entire fracture line. And even in the lateral view, it's not looking very encouraging. That was at 1 month. So probably plate was also pulling out. Bone profile done at the time of admission
was normal, including serum protein electrophoresis, and I had started the patient on teriparatide. 2 months later, again, there's a lucency at the fracture site. However, at 4 months' time, we are seeing two findings. Fracture had collapsed, the screws had backed out. However, at the lower screw junction, we can see thickening of the medial cortex of the shaft of the femur. The lady could never walk following the fracture, full weight bearing. While the fracture seems to heal, the thickening of the cortex seen at the fourth screw was an ominous sign. Let me remind everybody here that there was no history of bisphosphonates. Right at the day one, I thought this looked like an atypical fracture. I asked the patient, had she taken any bisphosphonates in the past? She said no. At 5 months and at 7 months. At 7 months, the fracture failed, where it showed non-union at the fracture neck femur, and then there is a fresh atypical fracture at the bottom under the plate. So this was a red flag right from the start. When I started to drill the fracture and the bone was rock solid, my decision should not have been to fix the fracture. But that decision was too late. We were 7 months down the line. So it broke under the plate. What was to be done next? Infection was ruled out. So the summary so far here is fracture presentation was always atypical, although there was no history of bisphosphonates. Index surgery, although quick, was not easy. Patient could never walk on this leg for 7 months. Still, she did not go away, came back to me. Bone metabolic workup was normal, and it was done at the first admission. Teriparatide was started, so at 7 months, surgery, revision surgery was planned. So what I planned here is to open the whole thing up using Cocker-Langenbach approach. I took out all the implants. Fracture was in frank non-union. I crushed the head to use as a bone graft. A cementless hip replacement using a Wagner system was undertaken. One specific thing, how I prepared the femur. I put a plate and clamps and cerclage wires, held the plate and clamps together, and that is how I reamed and prepared the femur. That's what it looked like post-op. I used stimulant granules so that there would be no infection. The crushed head pieces were put at the fracture site, and she was instantly happy. She could walk with partial weight bearing, and that's the X-ray. 6 months down the line, we can see some callus at the fracture site. There are no disasters to be seen at the tip of the stem. These are the pictures taken at 9 months, where it looks quite conclusive that there is callus at the fracture site and fracture is healing up well. And that's at 15 months time, where everything is healed up. She is fine, and she is finishing a course of teriparatide. She was allowed full weight bearing 2 months following the hip replacement. Evidence of healing was seen at 6 months. Completed the course of teriparatide. What next? A take-home message, detailed history taking, ask about bisphosphonates specifically, anticipate the surgery and plan ahead, fix or replace. This hip should have been replaced on day 1. Thank you.
Wonderful case, Dr. Sachit. If you can stop sharing. And I'm so happy that 2 consecutive cases, one of fixation and one of replacement. And as Sir correctly said, fixation doesn't really have any great results in the elderly patients, and this is proven immediately. So wonderful case, and I open it up for discussion if any queries, questions, or thoughts of this particular case.
Yeah. Shall I comment? Have comments, right?
Yes.
Yes, sir.
Yeah. Say fracture fractures of the proximal femur, all our hip bone is very much exposed to tremendous pressure on the while walking. The hip bone is very much exposed. Fracture neck femur, basal fracture, subtrochanter, all are very much exposed to hip. Tremendous pressure on the hip joint. So reduction is very, very important here. In this case, reduction was not so good and compression is also required. If reduction is not there, then fracture neck femur, basal, trochanter, subtrochanter, all are bound to fail. So in this case, the reduction is very important. If closed reduction is not possible, you can go ahead for open reduction and fixation. Fixation is very important. Reduction is very important, then fixation. And then, of course, they follow this. And then finally, the results are good, I think. What happened, arthroplasty was done, very good, well done. And ultimately, one has to learn from all these experiences. And because fracture neck femur, subtrochanter, basal are all fractures, are very bad fractures, and one needs to have complications, and then well solved. The complication was well solved. That's good.
Great. Thank you, Dr. Bhosle. And Dr. Chandra, if you're ready with your presentation, can we have you present now your case?
Yeah, can ready. We can start.
Yes, absolutely.
My case is, we'll share the screen. I think you can see, no?
Yes, it is just starting. Yes, I can. We can.
So it's a recovery from a complicated distal femur supracondylar fracture. And this case started, this is the initial most X-ray, which is 53, BMI more than 27. Initial road traffic accident happening and distal femur comminuted fracture, compound fracture. And this was happening in a remote place. So there's no orthopedic team. So they had done a wound cleaning and it was penetrating injury with a 3 centimeter skin laceration. So they had noted that surgical notes that there was a detached bone part, and the doctor who did the wound cleaning had removed that bone part. It's about 3 centimeter to 2 centimeter. Then she was later stabilized with the fracture with the ST pin, the Steinman pin to the proximal tibia and the plaster cast, and then transferred to a provincial hospital where they have the orthopedic facility. It's a AO classification C3, Gastilo 3A. In the orthopedic care services, they have reopened the wound, wash out, and irrigation done. Then soft tissue closure done without any tension. Again, stabilization done with the skeletal traction and plaster backslap. Microbiology was negative, and she was discharged from the ward after the 5th day. That is 5th day. Then readmission after 2 weeks. Then the wound was healed, and they had CRP was 16, and they had decided for the open reduction and internal fixation. And this is the X-ray, post-op X-ray you can see. And I invite you to comment about this post-reduction X-ray. The significant thing, other thing is, in the same admission, this is the initial surgery, this thing. In the same admission, due to some reason, the patient and surgical notes said they had reopened the wound and done a refixation. In the refixation, they had mentioned they had done with the bone graft, and they had went through the same plate. And if you closely go through this X-ray, you will see this is not very closely aligned X-ray. And even the plate is well fitted. The femoral condyle seem to be, lateral femoral condyle seem to be rotated. Then second X-ray, just critically analyze this X-ray for you all. And AP reduction looks okay, but the lateral reduction, lateral X-ray seem to be again the medial condyle looks rotated and seem to be the plate is not well secured. Then if you closely look at the X-ray, you can see the surgeon who put the plate, he had tried to use the same holes. You can see some previous holes, drill holes there, and he tried to push the same plate in the same drill holes. And medial condyle is not well sheathed into this locking plate. So it seemed to be not a well established plate. And patient was mobilizing with this plate, and after 13 months, she presented to me with complaint of severe pain in the knee and unable to walk and weight. Unstable plate with broken screw and fracture with non-union. In the clinical assessment, basically blood counts are stable, CRP low, and no clinical evidence of infection. CT was not done and due to the metal artifact effect. So issues comes with about the query of the infection, any debridement needed, correction of alignment, rotational issues, requirement bone graft, and fracture stabilization. I removed the metalwork first and then the microbiology assessment, and it became negative. Then once the wound healed, I fixed the distal femur with DF, which is distal femoral intramedullary nail, with some bone graft over the fracture side. And I noticed the very poor bone quality in the distal femur. On post-op 6th week, she started partial supported weight bearing, and post-op 3rd month, she started mobilizing off weight, and she was stable and reported to work. Again, after 2 years, she presented again in December, in the end of the year, and she complained of some pain of the leg. So in the X-ray, I noted the one locking screw is broken. Lateral condyle looks healing, the medial condyle is. So my impression was the locking screw failure is secondary to the poor fracture healing and fracture site strengthening. So I allow her to keep the weight bearing and continue the work and things. And I review again in April with the complaint of severe pain. Now you can see that both screws are broken now. And the nettle had just coming into the, migrated into the articular surface. At the same time, the lateral cortex seemed to be well healed. There seemed to be a bone defect in the medial cortex. So she didn't complain much pain on weight bearing, it's mild pain, but she complained of pain while flexion and extension movements of the knee and patella. So what I was thought of offering to her, that I offered a knee replacement because that interarticular involvement and these issues. And but there, you know that the femur with the stem is going to be a very cost. So I decided with the ready stemmable femur. And what I did was I pushed the nail a little bit up, about 1 centimeter to 2 centimeter, and then lock the nail. And at that time I noticed that fracture is well healed. Femur with the tibia with the stem for the tibia. So I packed the medial cortex with the bone graft, and it seemed to be now well healing. And instead of the femur implant with the stem, I was able to manage with the nail to support the fracture side and start the weight bearing. So we'll see whether this video is working. Now she's mobilizing with the weight with the walker. I just this case is open for the discussion, and you can comment about other alternative and treatment options available for this.
Great. Thank you. So if you can stop sharing. Yeah, so good innovative technique for a difficult problem to begin with. I think the arthroplasty surgeons would definitely have a view on this. So would the trauma surgeons. So yeah, Dr. Sachin is here, Dr. Nadir is here, Dr. Shakir Kapadia, all are arthroplasty surgeons. So thoughts, comments? Shakir sir, are you?
Swapnil, can I say something?
Yes, please, sir.
Really well managed case. Excellent. My only thought is a beautifully done TKR, I'm sure. But my only just a thought in my mind that why not resect the distal femur and put in a resection prosthesis like you would have done for a tumor? Would that have been a more simpler procedure? I don't know. Just a thought in my mind.
Reason is that I'm in Sri Lanka. Here, the cost is the main factor. So that I thought of unless it really indicated, why to spend additional money.
Right. Okay. True.
Dr. Sachin, Dr. Nadir, your thoughts?
I thought that I would be wary about infection. The TKR was really brilliantly done, and the nail was supporting the distal femur. But what was the protocol followed to any markers done prior to surgery? Did you send a biofire as culture sample during the surgery? Did you put any stimulant granules or any antibiotic therapy afterwards?
So it's basically before the surgery, in the initial setup, before even DFN nailing, I send the tissue sample for the culture, and repeatedly the ESR and blood counts, CRP and things are normal range. Even procalcitonin was negative. So even after the second last surgery, during the knee replacement also, I had taken the culture sample and sent for the microbiology. Those things were negative. And I didn't use any antibiotic granules, but only the cement, which is Palapos with gentamicin impregnate.
Yes. Yeah.
Great. Thank you. Dr. Matthias also has a thought, a comment.
Yeah, so just a small comment that for this type of failure that we see usually with the distal femur fractures is that we now have the tendency to go with nailing plus a medial plate to support the varus deformity. So usually these cases in patients older than 50 years old, we try to apply the concept of a nail plus plate, a plate from the medial side. And that gives us less chances for this failure to occur.
Actually, if you go through the initial X-ray, it seemed to be done by a junior surgeon, and it is the condyles were rotated. At the same time, the second time when they are reopened and fixing again, they had used the same holes. So obviously, the screw holding tension is less when you drill the same hole, put the same screw in the same hole. So that may be the reason for failure. Even the second X-ray, the alignment was not good in the lateral view. So I think the initial failure on the fracture reduction and fixation.
Absolutely. Thank you. We move on to the last presentation of the day, and that is a complex ankle fracture by our foot and ankle specialist, Dr. Samarth Thakkar. So over to you, Dr. Samarth.
Thank you, sir. It's great to see all the senior faculty here from across the globe. I'll be sharing this case of, I hope my screen is visible.
Yes, it is.
I'll put on the presentation. Yeah. So I'll be sharing this case of a late presenting PER ankle, malunion, non-union. So this 50-year-old male presents to me after around 5 months of trauma. He had this PER ankle fracture. Somehow he was conserved wherever he was in view of fear of complications, as he has already undergone CABG. As you can see, he has a great subfenestion harvested. We see his ankle on presentation to me in a standing view. We see here that in the AP view that the, 1 second. Yeah, we see here in the AP view that there's a gross valgus. The talus is laterally shifted out of the mortise. Medial malleus is in non-union and within the mortise. The high Weber C fibula fracture is malunited and shortening. In the lateral view, we see a flat foot that has occurred due to this deformity. These are his clinical photos. We see this subfenescent harvest incision from his old CABG. He already has a native flat foot, but this injured side is further flattened. There is a gross valgus, and when he walks, he has antalgic gait and a significant limp as well. His CT was analyzed. We see that the fibula has a bridging malunion already formed. The talus has 50% lateral shift and point loading at the center of its dome, the middle mal non-union. Fibula, as we can see, has a PER pattern anterior superior to posterior inferior plane of fracture site. The axial cuts show that the posterior lateral fragment is non-united and splayed apart with a wide syndesmotic gap. At the same time, shaput or anterior syndesmotic bony avulsion is seen, along with the posteromedial non-union as well. So the complete ring of ankle is broken, non-united. But as we go higher through the axial cuts, the posterior mal has a bridging malunion right to the metaphysis. This would render the posterior mal a stiff non-union with a malunion combination, wherein the intermediate area is full of fibrosis, the one between the fragment and the residual tibial shaft. We see point loading on the talus and some reduction in the joint space, although this is a non-weight bearing CT scan. But you can expect that the cartilage has thinned out there due to the sclerosis seen. These are just his examination video under anesthesia to demonstrate that the whole non-union malunion was completely stiff, immobile, despite maximum corrective manipulation given externally. So we have here a 360-degree problem. Anteriorly, the syndesmotic is wide open with fibrosis filling inside. Medially, the medial mal is non-union with fibrosis again in the ankle joint. Posteriorly, the posterior mal has malunion, non-union combination, again fibrosis there. And laterally, the fibula is short, externally rotated malunion. Plus, the skin, although does not have blisters or swelling per se, but has a post-CABG scar with GSV, great saphenous vein, harvested out. Not the best kind of skin to operate with multiple incisions. So the decision was to fuse the ankle or salvage the ankle. Because he was non-neuropathic and a non-diabetic male, and the Adelaide score, as is used by us to guide us with diabetic fusions, is below 5 in this case, we chose ankle salvage, explaining the patient well the pros and cons. Approach was a major consideration. We didn't want to have 3 incisions on him. We wanted to just have 2 to access these 4 quadrants of the ankle ring. We chose MPM approach, which tackled the medial and posterior side, and the lateral approach to tackle the lateral as well as the anterior aspect. Just a short note on MPM approach. MPM is medial posteromedial approach, recently described and propagated by Liverpool group of surgeons, especially Dr. Lyndon Mason. They utilize the windows between tibialis posterior, FDL, and around them so that the medial as well as posterior structures are addressed. This was the 3D CT that we got the patient's modeling done just to have a better preoperative planning and understanding of things. As you can see, the posterior mal is grossly non-united and splayed apart with syndesmotic gapping. I'll not go into the details of the plan, but the general sequence was to first debride and osteotomize all malunion, all non-union, all 4 quadrants of the ankle, and only then go into a sequential fixation with fibula first, then syndesmosis, then middle mal to recreate the ankle ring. Just doing the fibula debridement and fixation first while not addressing the medial and posterior aspects, debridement would not allow the ankle to reduce back. The ring is stiff in a malaligned shape. So this is a medial incision marking. We went ahead for the MPM approach, and the lateral incision marking cheated little anteriorly. First, as we went medially, we debrided the non-union of medial mal. We jacked open the middle malleus with lamina spreader and did intra-articular fibrosis removal, which is mandatory to allow the talus the space to come back in its original mortise space. Following that, we also ensured that the talus cartilage was decent enough to not fuse it. Next, As we can see here, the same approach allowed us to go posterior. We can see the great toe moving and the FHL tendon moving and the FDL as well. The tibialis posterior is also somewhere there. So we utilize this window to go in the posterior aspect. As we can see, the fibrosis in the non-union part of posterior mal was removed out sufficiently, as well as osteotome was used to osteotomize this bridging malunion in the superior aspect. Then we went to the lateral aspect. As I said, we cheated the incision a little anteriorly, so our syndesmotic access was complete. Superficial peroneal nerve is always a source of issue here because it gets stretched or injured. So we made it a point to first identify, put it aside with retraction, and then went into syndesmosis. We debrided the full syndesmotic fibrosis, and we can see here the talar cartilage is visible from the top. Thus, we know that the syndesmosis has space now to come back in position. Through this syndesmosis, we could also see the posterior malleolus. This toggling is of the Volkmann's fragment, and further curettage and debridement of the undersurface of this fragment was done through this. This would allow a non-union surface to get that freshness to unite back to tibia. Now, the fibular K-wires were planned at the malunion site. They were planned in such a way that they were rotationally offset. The distal wire was externally rotated out of plane. So when we use a Hintermann distractor, they are brought in plane. The external rotation deformity is corrected to a neutral rotation. Again, the rotational deformity extent was all eyeballed, but this is how we try to get the rotational correction done. This is us showing that on Hintermann distraction, the fibular length improved and the talus started shifting back into the mortise. This could happen only because both medial and posterior as well as anterior debridement was thorough and complete. This video is showing here that the fibular length had started gaining mobility around the neck. Once we got the fibular length, we clamped it with the syndesmosis with the clamp, got the reduction, confirmed that in the lateral views, the talus was symmetrically below the tibia. The posterior mal luckily was sitting back right in its place as was seen on the C-arm, and we put in multiple K-wires followed by multiple screws to keep the syndesmotic well reduced. All this while the fibula was kept distracted properly with a locked Hintermann. Then a long plate was put, longest plate available on the fibula, and bone graft was added onto the distraction side of fibula. With this, we realized that the posterior mal was sitting very well in its location. At last, we went and did the medial malleolus fixation with 2 screws. I do notice and agree that there was some mal reduction in the medial malleolus there. Probably we should have added bone graft so that the compression would have not led to mal reduction. At the end of this, we noticed that the talus was right below the tibia. There was no posterior subluxation, and the posterior mal looked very stable onto the posterior surface of tibia. We didn't have the courage for a third incision, so we said, let's not fix the posterior mal. We believed that there is a subset of posterior mal fractures that we see here that the tibia talar standing alignment is perfectly symmetrical. There is no joint space reduction. So whatever cartilage thinning probably has not contributed to gross reduction as of now. The posterior mal looks well united. These are his standing clinical pics at the end of 3 months, well aligned. His range of movement is still less. He's working on it. As we can see, there's a gross calf wasting because of 5 months of pre-operative wasting and 3 months post-operative wasting. He's walking right now at around 4.5 months. He's improving on his gait. What is for sure improved is that his pain is gone and his alignment has improved, but his speed of walking is gradually getting better. He's 6 months post-op as of now. So with this experience, for me, I took some valuable take-home points that ankle salvage is possible even in late presenting cases, as Dr. Stephen Rammelt from Germany has given good articles that up to 6 to 9 months salvage is still possible. MPM approach, a relatively new approach of dealing with ankle malleolar fractures, can be utilized in selected patients needing posterior access. And lastly, a rigid syndesmotic stabilization is sometimes enough where posterior fixation is not done. Again, it's a very controversial statement, point 3, but in selected cases only. Thank you. And probably the only different thing that could have been done here, and I got this feedback from one of the conferences where I presented, was that syndesmotic fusion was an idea. If done, that would have prevented the need for multiple screws and multiple long fibular plate. But barring that, I think the patient is as of now happy, and we are hoping things stay that way. Thank you.
Great. Thank you. Wonderful case, Dr. Samarth. Very well managed. Difficult problem, but well managed. And I open the case for discussion to the House if we can stop sharing.
This is brilliant planning and execution is very impressive. The case looked absolutely unsalvageable for a general orthopod.
Thank you, sir.
Can you stop sharing the screen? Samarth?
Sorry.
No, you're still sharing it.
Oh. Still sharing?
Yeah, still sharing. You have to stop sharing. Go to Zoom and stop sharing.
Able to find that point here.
Go to the Zoom and stop sharing.
Yeah, stop share. Yeah.
Great. Thank you, Dr. Samarth. Wonderful presentation. And with this, we call it a day, but such a wonderful bouquet of cases. And I'm so thankful to all of you all for taking out so much time. We started with 2 hours, but ended up with 3.5 hours. And still, most of us were glued to our screens. So thank you so much. And it was such a wonderful exchange and experience of all beautifully managed cases in different parts of the world with whatever limitations of treatment, implants, instruments, and finances we have. So from the bottom of my heart, I thank all of you all for contributing time, energy, and effort. And we will stay in touch. We'll continue with the group and we can keep posting cases for opinions because that is the only way we can grow by learning from each other. Thank you so much, all of you all. Thank you.
Thank you. Thank you.
Good night.
Thank you and good night. Thank you, everyone.
Thank you for.
You soon.
Thank you, everyone. Good night. Good night, everyone.
एक आशा YouTube